3D gate.
Hello. Check.
Gate analysis.
Check.
For the normal
Check.
section.
Check. Hello.
इसके चार
Osteotomy is around the hip.
सर इसी पे सॉफ्ट रोल लगा के सर ठीक है इस पे सॉफ्ट रोल लगा के
अच्छा रहेगा it will be easy for them to understand.
Then osteotomy knee, osteotomy hip, 5. Then all 3. Skeletal dysplasia is postponed. So is there for pediatric upper limb? For pediatric upper limb. Then another 2. So is for that is Mackenzie's son is coming.
Both Mackenzie and his son.
Both are coming. For skeletal dysplasia, they will also take up with plastic.
Mackenzie का होता है दोनों knee replacement.
Both are coming. You mean
Our side, he doesn't, Sukalyan is a young boy, he needs some guidance.
that's why it's exactly that's it.
Thank you. I'm very happy to provide guidance.
That's why I said I was not aware about this.
Then you are responsible.
That's why he said no, he's different. He's totally different. He will make sure.
No, but in a way it's good like you really take care of everything and
He doesn't know me well enough to start that.
it's already 8:45.
yeah, please tell me.
So good morning everyone, welcome to the day 2 of pediatric foot and ankle course. So we are starting with the trauma sessions. Hopefully everyone had breakfast, and we have 3 sessions today: trauma, deformities and miscellaneous, followed by workshop on sawbone model. So the chairpersons for this session, Dr. Bashir sir, please. Dr. Ritesh Pandey. Vinod Thakur sir. Yes, sir, please. Dr. Sukalyan, please. And the first talk is by Dr. Sandeep sir, and he'll be talking on pediatric foot and ankle fractures.
Thanks, Jaswinder. So I will be, though the topic is foot and ankle, I will be mainly talking about ankle fractures. Foot fractures, with a very few exceptions, most of them are managed conservatively with immobilization in a cast. So ankle fractures, I'm going to talk about distal tibia fascial injuries, and then I'm going to talk about a specific special subcategory of fascial injuries, that is the transitional fractures. So first, distal tibia fascial fractures. So this is an injury. How do you classify this? How do you reduce this? And do you need to fix this? And if yes, then how do you fix it? So the classification of distal tibia fascial fractures, you can do this by the Salter-Harris classification, which is a generic classification for all fascial injuries. But the classification that is specifically used for distal tibia fascial injuries is the Takjan-Diaz classification. Now you can see that there are 4 categories of injuries in this classification, and there are 2 terminologies in each category. So it's a supination inversion, or it's a pronation eversion external rotation, or it's a supination plantar flexion, or supination external rotation. Now out of this, the first terminology, that is supination or pronation, that gives you the position of the foot when the deforming force was applied to the foot. And the second terminology, it tells you the direction of the deforming force. So in a supination inversion injury, the foot was in a position of supination, and then an inversion force was applied to it. Now, how do you identify what is the, what fracture are you dealing with? So that can be identified from this table And I will just give you an example how to use this table. So take this injury. This is the X-ray which I put up initially. So here the displacement is in a posterolateral direction. The fibular fracture is high and the metaphyseal beak is lateral. Therefore, if you go back to this table, this is a pronation, eversion, external rotation injury. Another example, here the displacement is medial, fibular fracture is low transverse, and there is no metaphyseal beak here. So again, you go back to the table and this is a supination inversion injury. So this table can be used to, identify in what category your, fracture is fitting. Now, how do you treat this? So, almost all the fractures are treated by closed reduction. Very few situations you require open reduction. So for closed reduction, what you necessarily need to do is you need to reverse the deforming force and you need to immobilize in opposite direction. So here the Tugjan classification comes in. From the Tugjan classification, you know what is your deforming force. So you have to reverse that and you have to immobilize in the opposite position. So for example, this is in a supination plantar flexion injury, you need to dorsiflex the ankle and then immobilize it in a position of pronation. Similarly, in a supination plantar flexion injury or pronation external rotation, eversion external rotation injury, you need to invert the foot and then you need to immobilize in a position of supination. So that's how you do a closed reduction. There is one caveat over here or one word of caution over here. Beware of gap at the fracture site at the end of your reduction. This could mean an interposed periosteal fragment, and this has been described, and this is a predisposing factor for a physeal growth arrest. So if you see this gap, then it is an indication for going in, just opening it up, taking out that periosteal flap and closing that gap. Do you need to fix these fractures? So most of the type 1 fractures which are adequately reduced by Salter-Harris type 1 fractures which are adequately reduced by your closed reduction maneuver, you don't need to fix them. If at all you fix them, you can do this with K-wires. But in Salter-Harris type 2 fractures, where there is a large metaphyseal beak, you can make use of this beak to do the fixation. So you can fix these fractures with metaphyseal screws like this. By doing this type of fixation, you don't need to breach the physis. Your physis is completely safe. Same thing with the Salter-Harris type 3 or 4 injuries. Over here, you can put an epiphyseal screw, a transverse epiphyseal screw. Again, you don't need to breach the physis, and this is a very safe fixation. Now, many times, surgeons do the mistake of, underestimating a minimally displaced Salter-Harris type 3 or 4 injuries. But remember that these injuries are fractures of necessity. They need to be fixed. The reason being, even a slight amount of malunion in these fractures will lead not only to articular incongruity, but it will lead to a step off at the level of the articular cartilage, and that can lead to a growth arrest. Example being this. So this medial malleolus fracture, because it was minimally displaced, it was, conserved. However, you can see that there is a step off at the level of the articular cartilage, and that has led to a growth arrest and deformity. Now coming to a second, subcategory of physeal injuries, that is the transitional fractures, and these are so called because they occur in the transitional age group between adolescence and skeletal maturity. We know that the tibial distal physis, it starts, fusing first in on the medial side, and then the fusion goes centrifugally towards the whole of the physis, and these fractures occur exactly in that transition period. That is, partially the physis is fused, but part of the physis is still open. So there are two types of transitional fractures, triplane and tilo. Triplane fractures, these are peculiar fractures in that on the AP view, they look like Salter-Harris type 3 injuries, but on the lateral view, they look like Salter-Harris type 2 injuries. But actually, if you go to see, these are, on the lateral view, they look like Salter-Harris type 2. But actually, if you go to see, these are Salter-Harris type 4 injuries. In order to identify the exact pattern of the injury, a CT scan is a must. And what the CT scan tells you is that at the level of the epiphysis, the fracture is generally in an anterior-posterior direction, but at the level of the metaphysis, the fracture is in a transverse direction. So this is a three-dimensional fractural configuration. The mechanism of injury is external rotation. So to reduce these fractures, again, you need to reverse your deforming force. How do you do that? You can insert a K-wire into the anterolateral fragment and then derotate or, internally rotate your leg in order to reduce the fracture, and the same K wire can then be advanced, and this wire can then be used as a guide wire to put in your screw. The CT scan guides you to know the exact screw configuration. So in the epiphysis, you need to put generally an anterolateral to posteromedial screw. In the metaphysis, you need to put an anterior to posterior screw, something like this. Telo fractures, again, these are again transitional fractures, and an anterolateral fragment which is attached to the distal anterior tibiofibular ligament, that is Avelsdorf. Again, these are external rotation injuries. You put in a K wire into the fragment, internally rotate these, and then fix this, something like this. Okay, so this is about distal tibia fascial injuries. Be careful to identify the triplane fractures, and if you see a triplane fracture, you should do a CT scan, plan your fixation, and do it accordingly. Thank you.
Okay, so we come to neglected injuries in the foot and ankle in the pediatric group. And as a principle, remember the child is not a small adult. The problems in trauma are also different in that non-unions are really very uncommon in the child, but malunions are much more common. And you need to be aware of problems related to the physis. That means growth plate and growth disturbances, growth plate injuries and growth plate disturbances. So we'll start with a case. This is an 11-year-old boy who fell from a height of 20 feet, was treated in a POP cast for 45 days, and he came with pain and swelling in the left ankle with a plantar flexion deformity of about 15 degrees and a jog off movement. So that was the X-ray that we saw and the CT scan. So how would you deal with this? So this is a problem because this bump there is going to stop him from dorsiflexing the ankle. So he's going to be stuck in plantar flexion. So even though it's late, you still need to do something. So you need to go in, you really recreate the fracture because you can still see the fracture line there, and then reduce it and then fix it with screws and threaded wires. And then we put a distractor on to keep the joint distracted so that otherwise the tendency would be for it to get compressed again and cause problems. So that is what we did. You can see the subsequent x-rays. Once we took out the frame, now you can see that the ankle is now within the joint and it's reasonably well held. Obviously, you need long-term follow-ups on these. And I think this patient this is about a year down the line. He's still doing quite well. And then we, I think, took out the screws at about a year and a half. Here's another interesting case. This is was a son of a neurologist and daughter of a neurologist, very obese, and this was her initial injury. And this, if you followed the classification, would be a classical supination inversion injury. Okay, so what happens there is very often this is like a type 1 injury, while here you have a type 4 kind of injury. Okay, so this actually is a more vertical fracture line which tends to go across the physis to the metaphysis. So this was what was done. Okay, now this was done by another senior surgeon in Patna, and I was out of town. The moment I got back, I got this desperate call from him, no, you need to do something, because this x-rays had been sent all around the world by this neurologist. And he said, no, you have to. And I was very scared at that stage because and she's really obese, this child. Okay, so okay, I said, okay, now I know, but because she was about 10, I think she was 10, so I knew that there was not that much growth left. So the intra-articular problem was a bigger problem than the growth problem. So we went in, that was the kind of hematoma that we had. You can see the periosteum there was, we had to actually do an open reduction to get this back. And then we put a screw across. What's happening to this? It's too sensitive. So we put a screw across to reduce the articular area, and then this threaded wire which we put into the metaphyseal area, avoiding the physis. So we were able to avoid the physis with the fixation. Usually the fibular fracture in these fractures do not need fixation, because once you fix the medial side, it would tend to get into place. But of course, you need to make sure that is reduced. And then she went on and followed up, and she did well. And she actually got to skeletal maturity. Okay, unfortunately, I don't have her later X-rays and the follow-up, but we in fact removed the implants almost 3 or 4 years later, and she was doing quite well. Now, here's another situation. This is the kind of problem that they develop if they've not been managed adequately. And this is a 10-year-old who ended up with, now here you've got a physeal arrest. You've got this entire medial side where the physis has arrested. You can see the fibula is still growing, and you have this deformity, and this is going to progress. So what you need to do here is you have to correct the deformity. Now you can do that in one of several ways. You can do it with an opening wedge osteotomy, or in this case, we use the Ilizarov to do a gradual correction, but you also need to close the growth on the fibula. Okay, so you need to do an epiphysiodesis of the distal fibula. So here you can make it with multiple drills. You can put a screw across it, and also the lateral part of the tibia, because that is also still growing to cause this deformity. So you do that. That's what we did. We did an epiphysiodesis plus a sort of gradual distraction correction. You can see the hinges are very low so that you get the minimal translation. So there's a little bit of translation, but it gets aligned in terms of the mechanical axis. And this goes on to heal nicely. And you can see on the follow-up, it's got a decent ankle. And this is about 1.5 years follow-up. It's still maintaining the correction. And because the growth in the fibula and the lateral physis has been also closed, it's maintaining the correction. And now he's almost 13. So hopefully it will not recur significantly. The last case, so that's the last follow-up we have. So it's still doing quite well. The last case is actually a post-Burns contracture, bilateral. And you can see that one of them has gone into extreme dorsiflexion so that the foot is actually aligned with the tibia, and the other one is in equinus. And here's where I think the distraction methods can come in useful. Obviously, you're going to need to release this tether here, and then you can put a distractor on. So we use the Jess fixator, one going the reverse way for the correction and the other the standard way for the correction. And you can see how gradually with the distraction, the skin also kind of tends to form over that area. We didn't actually graft, except the initial surgical part where we released that, we put skin graft on. The rest of it, the grafted skin stretched out with the distraction. And you can see again, that's the X-ray pictures as it's gone into correction, and a clinical picture. I mean, it doesn't look perfect, but a great, much better correction. And she's able to walk on this foot. The sole luckily was okay, so she went on to do quite well. So I think you can have varied presentations with these neglected injuries. I think you need to assess them carefully and then choose the nature and timing of your intervention. There'll be some situations where really doing anything will be pointless, and you end up with doing salvage procedures later. But where you can change the course of the malunion or the prognosis in the long term, then it's worth intervening. But you have to decide when and how to intervene in those situations. Thank you. So I think ankle fractures is something which is has not been very common in India, but we are seeing more and more. As you're finding younger people involved in sports, you're going to get more and more of these injuries in younger patients, and it's a lot of them get mismanaged. So I think it's important that you learn about ankle fractures, learn about the transitional fractures and the patterns that they come with in the child.
Sir, in your third case, where you have described about the growth arrest of the distal fibula, and you have asked to use the drill for destroying the physis. Can you use the malular screw?
Yeah, you can use a screw. That's why I said either you do that or you can put a screw across the physis.
And what you have did for the distal physical remaining part, remaining lateral part of the.
So we just drilled across them.
Okay?
Yeah. So that's more or less Okay.
And sir, what follow-up period? 2 or 3 years, I think.
I think we have got a 2-year follow-up.
Yes, sir.
You were actually, so he was 10 and a half, so he's 12, but you really need to follow them up to skeletal maturity. But in 2 years, if it hasn't deformed, then the chances are it will remain okay.
Other than the Elizaro, can we use the supramallear
I mentioned, I think you weren't listening very carefully.
Yeah, sir.
I said you can do the osteotomy.
And which one, sir? Lateral.
I'll discuss that in my
Okay.
lecture. I
Yes,
will
sir.
discuss.
Yeah. Because it appears a little bit easy than this.
No, but you can get some length with the Ilizarov, okay?
Yeah, that is it.
So with the distraction, you get some length as well, and these will shorten up. So because although the distal tibial growth is less
Yes.
as compared to the proximal tibia, but they will get some shortening.
Yeah.
So with an opening wedge, you can compensate a little bit for the length. Okay, with the distraction. Yeah. Okay, thank you.
I think the commonest mistake that occurs with, ankle fractures in children, as Sir showed in his, sequelae, is the minimally displaced medial malleolus. You tend to underestimate them thinking that it's a child and it's minimally displaced. But the thing is that it's a Salter-Harris type 3. It has to be perfectly anatomical. Otherwise, forget the articular congruity. The problem is the growth plate. The growth plate gets malaligned, and that is going to cause a growth plate and growth arrest and further problems.
Sir, there are types of these triplane fractures which have been described, like comminuted types, 3 parts, 4 parts. So in those cases, what will be your statements? Which to deal first? Which fragment to fix? What will be your sequence of fixation?
No,
How do you proceed? Yeah,
Yeah,
triplane injuries.
there are different varieties of triplane fractures. This was a basic talk, but yes, the CT scan gives you invaluable, information. And basically, you have to plan out for each individual case. We can't have a, one fits all, formula for this. You have to see how the fragments are. But generally, if there are 2 or 3 fragments, what you have to, try to do is first convert it into a single fragment, and then align it with the intact, anterolateral fragment by rotating inward. So that would be my approach. That
I think in the fresh cases, we can still mostly manage with close reduction. That's where the CT becomes important in trying to know the direction of where you do your.
My question goes to John, sir. Excellent presentation, sir. So in doing supramalleolar corrections in chronic cases, do we come across the compensatory mechanisms that the foot plays? So, and how often do you have to address that?
Yeah, so for long-term problems, that's a big issue that comes in. So you sometimes need to tailor your correction to not overcorrect, because then so if you have a varus, because the foot has gone into valgus, if you get that back, you'll end up with a valgus deformity. So you need to watch your correction and stop once you think the foot is properly aligned in those. So usually these patients with the ring, you can watch them as you're correcting. So that's one advantage. If you're doing an acute correction, then you really have to try and find out how you so you check the ankle position before you do your correction at the supramalleolar level.
One more point I want to say that what Sandeep said is correct. The malaligned physis, but with perfect reduction of physis, also supination, inversion injury, it will lead to the growth arrest on medial side. So whenever we'll see the supination, inversion injury, always say about the prognosis to the parents, because they will blame also, because they have come on first day. Still it can go for the virus. So those cases will require very good follow. And then we can detect. And what he was asking about epiphysiodesis, if we do about the distal tibia epiphysiodesis, the approach is absolutely correct, because the distal tibia epiphysiodesis can lead to the 40% limb length discrepancy. So we have to do about the lengthening later if we do the supramalleolar osteotomy. And one more point for a 2-part, 3-part, and 4-part of triplane injury, which is the most displaced, we need to fix first, and the articular part would be given the priority, then rest of them. So whenever we do fix it, always see the epiphysis alignment is the best, articular congruity is best, then it will be rest to the matter.
First to reconstruct the articular surface, and then.
Yeah, and you may sometimes have to open it, but in the fresh cases, a lot of them you can get closed. Okay, so.
Also, sir, in younger children, neglected injuries where you have a growth arrest and deformity is progressing. Do you consider bar excisions, because in post-traumatic cases it has good results?
Yeah, but then it has to be a bar that is appropriate for in terms of size, the cause of it, etc. So if it's a huge bar, then it's no point. If it's a smaller bar, yes. And then personally, very little experience with bar, but I'm sure Hitesh would have some.
Yeah, the problem with the bar is there, as sir said, that it is to be mapped. We need to map the bar. And second, it is whether it's a central bar or a peripheral bar. Again, peripheral bar is not a good result. We'll have a central bar. And many times, if you see about the shoulder arrest type 3 and 4 or supination inversion injury, that would be peripheral bar. So that is the reason the result would not be as great. And if it is associated with a great amount of deformity, we need to correct the deformity also. Otherwise, the bar excision, because growth remaining is less, particularly in adolescent. So yes, I agree with the facial bar excision, but if it is less than 25%, very mild deformity, and facial bar excision would be a good idea.
Thank you, sir. So now we will proceed with the case-based discussions by Dr. Jaswinder.
Yeah, thank you, chairpersons. So in this trauma session, I have two cases to show. The first is, I think, well discussed by now. So this is a 12-year-old boy, and he has an injury to the right ankle. So because this is a discussion session, may I ask chairpersons and other faculties here, so what is the injury pattern? So we see a fracture in the tibia as well as in fibula. So I'm sure everyone agrees that this is a triplane fracture. Triplane, there is associated fibula fracture also.
Yeah, and you don't have that obvious intra-articular extension, although it could be there somewhere, but you don't have that
this
type
line
3 fracture line on the AP X-ray that you normally have with the triplane.
It looks more like a type 2 Salter Harris.
Yeah, this is that Thurston Holland sign is there with the fibula fracture. So as Sandeep sir mentioned and stressed that, of course, we'll get a CT scan to understand the fracture pattern. These are the CT images. So conservative versus operative. Yes, sir. Yes, sir. It is a type 2, yes, sir.
Can I ask a question?
Yeah, sure.
How is the pain of the child? That is very important and pertinent to this particular fracture.
How is the?
How severe is the symptom? How severe is the pain? Is it out of proportion?
If you're looking for, I mean, compartment syndrome, then not that much, but there was pain, of course, because of the fracture.
Okay.
Yeah, and there was there was swelling, but not as severe as a compartment types.
Because this particular fracture can cause superior extension reticular syndrome.
Okay. So moving ahead, so that is a fracture which is seen in the sagittal plane, the axial planes, and of course in the coronal plane, it's not.
Would you intervene or not?
12 days. Age?
Age is 12 years.
Boy or girl? Boy.
Yes, sir.
So he has significant growth remaining. It's a 12-day injury. You know, manipulation at 12 days, there is a high risk of causing an iatrogenic growth arrest. The displacement is more or less in the, you know, the sagittal plane. There is slight amount of valgus. What I would do is just, you know, give a molded cast, a gently molded cast, try to correct the valgus as much as is easily possible, not apply too much force and leave it at that. Not do any, you know, aggressive manipulation under anesthesia, try to get an anatomic alignment.
Didn't work. Actually, if you look at it, there is a displacement in this in the CT on the coronal plane as well.
There is that rotation also. There's external rotation in that.
Was the other thing. We couldn't get his ankle to neutral.
So those are the 3D images. We have already talked about triplane fractures. So we went ahead with the plan of close reduction if possible with percutaneous screws in this patient. And so we did a mini open type to try to reduce it. Of course, with close reduction, it was not coming. With mini open, we thought we'll pass 1 or 2 screws and wires and we might get a reduction. So that is what happened. So after trying, this was the maximum with the close reduction. We tried to put a screw, but again, after that, there was that much of gap. So we had to open it and we had to open reduce it, and that is a fixation. We had put 2 screws with kind of that washers. There was soft tissue interposition, sir.
We couldn't actually reduce it.
So we had to take out some periosteum a little bit.
Eventually, but
yeah.
Closed, it was not coming. Even with a lag screw, it was not coming. So then we opened it. Actually, initially we tried closed, it just wasn't coming. And then we ended up opening it. I think it's yeah.
Yeah.
It's debatable as to whether we needed to intervene. That is the one question that you can still ask and follow.
In case of the type 2 injury, the physis would not be involved, if they're not fractured through the germinal layer. So if we do about on the metaphyseal side, it will not lead to the more problematic. But what Sandeep said is there, many times it is the consensus is there to avoid the manipulation of the physis after 7 to 10 days. But if you do on a pure type 1 and type 2 injury away from the physis, it will go okay.
See, the problem with this injury is like there are 2 incidents which leads to growth arrest. The first is which has happened before patient coming to us at the time of injury. We don't have any control on that. The second is our treatment, the problem. So here, I would think that probably we are adding to the already possibility of the injury because it's 12th day. If this would have been a day 1, definitely there is no question about treatment. We have to have anatomical reduction. That will definitely reduce the possibility of everything. But on 12th day, yes, what John said is absolutely right, that it is debatable and it's only the long-term follow-up tells us about what has happened.
So moving ahead, that is a 5-month follow-up of this patient.
Probably there is a
yes, the physis has fused. But as such, function-wise, and he's able to do all the activities. That is 8 months follow-up. And that is 1.5 years follow-up after the implant removal.
But at the same time, it may not be all the time. Yeah. So we have to be cautious that one good case does not mean that.
Is it now 13?
Yes, 13.5 years.
13. So be watchful because fibula physis is open and the tibia physis is closed. So we keep in even after implant removal, observe it. If you see the level of the malleoli, the plafond of the this is actually little shorter than this side.
Looks little high.
So you please keep in follow up because it's the fibula physis is open. Tibia physis, the tibia is look shorter and it's a 4 millimeter into another 3. So it will have another 1.2 centimeters short.
Right.
Just to play the devil's advocate, I mean, if you had conserved it, the worst case scenario would have been that you would have landed up with some amount of malunion, which you would need to, if it doesn't remodel, you might need to do an osteotomy at a later date. Whereas if you have operated and you landed up with a growth arrest and deformity because of the growth arrest, then you are, subjecting to much more, significant surgery.
So what would you do if this patient came in the first or second day and you couldn't get a close reduction.
If yeah, on close varus, close reduction, if it doesn't reduce, it probably means that there is some soft tissue interposition. So I would have opened up on the side where the physis is opening up. See, you retracted that, and yeah. Yep.
Yeah, and yeah, if it is causing that, if
Yeah, but then if the fibula doesn't grow and the tibia grows, you're in trouble. Okay.
No, but the basic is to get an MRI and confirm
Yeah.
that the growth arrest. And if
But
yes,
that's
what you
later.
said is right.
No, but not at the time of surgery because you don't know.
But then the question of the limbal discrepancy is going to be there, sir. So that we have to tackle the opposite side.
yeah, so we are fortunate that it is not that place. The place at the distal femur, even type 1 and type 2 injury will lead to the growth arrest. So it is, we are not talking about distal femur, but distal femur, the growth arrest is also very, very common in type 1 and type 2 injury, not even 3 and 4. So 3 and 4 and 5 definitely will lead to the growth arrest. But so we need to be really very, very aggressive in a distal femur, irrespective of any injury.
So moving to the second case. This patient had come in initial days of my practice. So this is a 9 years old female, and she had presented with a right ankle injury. So can we read? I mean, of course, there is a swelling and there is some kind of bump which is palpable on the anterolateral side, and those are the X-rays. So please, any takers for this? There's a fracture of the medial malleolus. Anything else we can see?
There's fracture dislocation of the talus.
So those are the better X-rays, sir. So there is a talus fracture with a medial malleolus fracture, and the talus is quite comminuted. Sir?
It's dislocated as well.
Dislocated with that fragment of the talus, which is on the anterior lateral side, that bump was felt. It is kind of the ankle was locked in that position. I tried to manipulate for a close reduction in the emergency. It could not happen. So that I just wanted to put it back because the ankle looked dislocated. Yes. So those are the CT images. She's 9 years. So how do we?
Which approach is an important question because there is no doubt about that we have to reduce it. But which approach?
Medial malleolus is fractured. That would be that would be your best approach, isn't it? Medial, anteromedial, and then you might have to add a lateral approach.
The problem is the fragment is locked on the lateral side. So in spite of, yes, it gives a window, the medial osteotomy, malleolus osteotomy is already there for us to enter. But with that also, we could not, I mean, there might be a possibility that we are not able to open reduce from the medial side.
Yeah, but we can do, because medial malleolus is already fractured, we can go from there, because we have to fix the medial malleolus. And we can use the joystick to bring that fragment out. Can happen also from the medial side.
Right, sir.
From the medial side and put the threaded feet on the.
I think a distraction is very important in these. So you use a distractor across the thing.
You invert, no? Pilot and invert, so that will be you can see.
So talus fractures in children, they are quite rare. It is 0.008% of all childhood fractures, and it results from an axial loading of talus against the anterior tibia with the foot in dorsiflexion. And because the pediatric foot is flexible and less brittle as compared to the adult, and that is why they can sustain higher forces before they get fractured. The site, the talar neck is more common than the talar body. Of course, for the undisplaced one, we can go for cast immobilizations, and there can be complications like as in adults, there can be avian arthrosis, delayed union, and neuropraxia. So I started with a medial approach. I could not reduce it. And then, so I had to add an anterolateral approach. So this was on table. I tried to reduce it against in anesthesia also. It was not possible to reduce it. So that is on the medial side. We started with that. There is a fracture that is on the lateral side. That is the proximal talus fragment, which is kind of dislocated and locked on the anterior lateral. That is a fibula. And that is a fracture there. So fixation, sir. And it is quite comminuted at the same time. Yeah.
And get as close to an anatomical reduction as possible. In this case, it may not be 100% possible, but you have to try to get the best possible reduction. And then the screws fixation would be with screws. If you can, if it's through the articular part, then it has to be countersunk or headless screws. If it's through a non-articular part, then you can use regular screws.
So as said, I did everything, but there was something wrong here, or maybe I would not have done. I fixed the talus with screws. That is how I fixed it. I got a reasonably good reduction intra-op, which I could see. That was for the for the fibula, that one screw I passed horizontally, but I should have passed a wire. That was in my initial days of practice. I did not realize, and I passed a screw there. So of course that either this might have later on.
Just go back to the first X-ray.
So this is these
No,
are
the first X-ray. Okay, so there's no metaphyseal portion to the fracture.
There was a small metaphyseal
Small,
peak
yeah.
there, sir. Yes. I should have, sir. That is what I'm saying. So that is just the intra-op images. And of course, I added a fixator just to keep it in a little distraction mode. Those are the post-op images, immediate post-op. And then when I was about to remove the fixator, this is at 3 weeks post-op. At near about 6 weeks, I took out the medial malular screw also. I mean, it was with near the fixator, that is near about 4 weeks, I took both of them out together in the OT. So this is roughly 6 weeks post-op. That is only one image I have at 3 months, and that is at 1 year follow-up.
Growth arrest.
Yeah. So the growth arrest maybe because of I had done it, or might be it is because of the initial fracture pattern. I had explained from the beginning that there might be a growth arrest. So the patient father was quite ready to accept that. And recently, very recently, he had sent this is at 2 years follow-up, implant removal had been done. After this, I don't have x-rays because he doesn't want to get any new x-rays done. But that is the last follow-up at around 6-7 years after the initial injury. As such, she is very happy. She has no pain, no complaints at all.
Oh, yeah. So she was very close to skeletal maturity already.
So Jaswinder.
So the message to all the young people: do not cross the physis with a screw. It can cause a permanent damage. Put a wire. Yes, please, Ritesh.
So what was the sequence? Means you fixed talus first or the tibia first?
I had a window for the fixation of I did talus fixation first, followed by malleolus.
Because it's important here to maintain the relative width of the distal tibia and talus. That is also an important.
See, my concern was first getting a good reduction for talus, and I of course had to put the incision on both the sides. At the same time, it was quite a comminuted fracture. It was not like I could have done a percutaneous kind of thing. So I reduced talus, fix it with screws, finish my talus fixation, and then finish the tibia part.
Usually, what I prefer is to fix the less comminuted fracture first.
No, but in adults, in fact, osteotomy of the medial malleolus is an approach to the talus. So if your medial malleolus is anyways fractured, It gives you good exposure to the talus. You
talus.
fix the talus, and then the medial malleus can be fixed comfortably. That is
Access to view your reduction of the talus. So if once you fix that, you're not going to get that direct views, because especially the body is also involved. You need to visualize that part. And that is where the medial malleolar osteotomy helps you. Okay.
Okay. This, okay, right. Any more questions? Yeah, Dr. Open. It was a neck fracture, and it was, and it was comminuted also. Neck.
It extended to the body. It was not
Extended to the body. It is a comminuted.
By this way, sir, yeah, he did. By this way, sir, we can reduce the talus very easily, and up to 100% reduction we get by 2 incisions, rather 1 incision, sir, as we have.
So nowadays, no. This,
This is one.
Anyway, for most talar fractures, they recommend incisions for the reduction.
Yes,
Okay, in adults, anteromedial
Yeah.
and a lateral incision first, because if you put compression screws on the medial side, you end up putting the talus into varus.
Yeah.
And that causes problems long term. So the recommendation today is that if you put compression screws, you put it on the lateral side, and then on the medial side, you would put fully threaded screws,
Yes.
or sometimes or you can put a small plate on the lateral side and then fully threaded screws on the. So you do not want to compress the medial side, because then you get a varus of the neck of the talus, and that causes problems later on.
Thank you, sir.
Okay, so we are on time, and if we don't have any more questions, we'll end this session now. May I thank the chairpersons. The faculties will be felicitated later also. For the next session is deformity session, and for the next session, the chairperson, Dr. S.P. Gupta, sir, please come on the dais. Dr. Dinesh, please. Dr. Nand Kumar, sir. And Dr. Ravi Shankar is here. Ravi?
Hello. Now we should start with the second session. I will request Dr. Dhiren Gunjwala. Hello. Dr. Dhiren Gunjwala, please come.
Some question about that. So what we are going to discuss in this presentation, the first, what are the causes why we see coronal plane deformities, how to evaluate them, and the last thing about management. So first of all, causes. Now we need to remember that this deformity can be above the ankle or below the ankle, means at the subtalar joint. So the most common cause are infection, post-traumatic, like we discussed a lot about that in the previous session. The exostosis will reduce the growth on one side, and that leads to angular deformity. Or like we discussed yesterday about the paralytic condition, spina bifida or cerebral palsy will also lead to this deformity. So this is a case where patient had a road traffic accident and there was a severe soft tissue skin loss, and that resulted which was treated well, but ultimately that leads to a varus deformity. We already saw a similar cases in the previous session, so now we all are aware about this. This is about exostosis, where a big exostosis both from the lateral aspect of distal tibia and the distal fibula will result into a growth arrest, reduced growth on that side, not growth arrest, but reduced growth on that side, and that will lead to a valgus deformity. This is another case where there was an infection and that result into the loss of physis or severe problem with the growth, and that resulted into the severe varus deformity. Now this case shows that why we need to treat fibula, because we can see that it has resulted into a problem. So if we are watchful, then we can avoid this deformity going to this extent. But yes, in India, we see this cases very frequently. Then we see the below the ankle joint, and that's valgus at the subtalar joint. Usually that's a valgus at the deformity, not varus. But in a paralytic condition, we may see varus also. So the most common one, the flexible flat foot, which we discussed yesterday. The tarsal coalition is another problem which we see at that area. Or sometimes overcorrected club foot, not with the pauncity, but with the previous surgeries which were very popular, complete subtalar release, where 20% of the cases were going for overcorrection. And in those cases, we used to see this problem. And we will see something about spastic planovalgus foot, which is very common in cerebral palsy and spina bifida. So this is a case of flexible flat foot, where we can see the complete loss of medial arch. This is a case of cerebral palsy, where there is an extreme valgus. On one side, it is more than the other side. This is a spina bifida having a severe valgus fit deformity. So the next question is, why should we treat these? This is a very important, because when it comes to explaining the family, we need to tell this to the family. The first is cosmosis. But a lot of people say that anyway, it's going to be hide in the shoes or underneath the trouser. Why we need then cosmosis correction? Yes, in that case, basically that leads to shoe wear. Fine, that is also like we are ready to buy few pair of shoes at every few months. That's not a problem. But in over a period of time, that abnormal weight bearing leads to callosity and then pain. This will not happen immediately, but may happen after 10 or 15 years down the line. And osteoarthrosis of the ankle joint or a subtalar joint, again in the future. So pain may not be present at the time of presentation when they come to us, but may appear later on. And one of the reasons could be osteoarthrosis of that joint due to the abnormal loading. How we evaluate them? The first and the basic one is like we look at the clinical point and we look at the range of motion of ankle and the subtalar joint. We ask the child to stand on the toes. There are two things happening when the child stands on the toes. The first, the tendo Achilles is relaxed. So whatever is a component of tendo Achilles, that is taken away. And the second is like when child is standing on the toes, there is a hyperextension of the MTP joint, metatarsophalangeal joint. So that causes a jack twist. So again, that tightens the plantar fascia, and particularly in the flexible flat foot, this is a very important test. And the most important thing, if we are thinking of a surgical correction, then radiological assessment is very important. So this is a case where like a child had a valgus deformity and a flat foot, and the same child when standing on the toes. Now what happens with plantar flexion? The tendo Achilles is now relaxed because the foot is in plantar flexion, and the jack twist is also being there. And now we can see that now hind foot goes into varus. So the important information is that this is a flexible deformity. There is a correction taking place at the subtalar joint. So this is a flexible variety of the deformity. Coming to the important part, the radiological thing, we need to take a standing AP and lateral view. But the important thing is like this helps us where is the deformity if it's present. So that is the most important information we get. It also tells us about how much is the deformity, which is very important for us when it comes to the surgical correction. So these are the AP views, which tells us that what is the reason of deformity, how much is the deformity, that information we get. So for that, we draw a line passing through the shaft of the tibia, and we draw a line parallel to the articular surface. That's a distal physis. If it's a unilateral deformity, the normal side becomes a useful information for us, and we can compare it that this is angle, the distal lateral tibial angle is 87, and we can compare that on this side, there is a 120 degree. So almost 33 degree deformity is there. So this view gives us idea about the amount of angulation at distal tibia. This is useful for the deformity which is above ankle joint. If the deformity is below, then we need to go for a spatial view, which is a hind foot view for looking at the amount of deformity. So how we take a hind foot view? So let's take this is a foot. We keep a plate at 20 degree to the vertical line. So this is a radiologic plate, and the X-ray beam comes perpendicular to the plate. So this is the view which gives us information about hind foot. The previous view which we saw is good for the above ankle, but it does not give us any information for the deformity when it is below ankle. So this view is very important. And we try to look at this view, and we look at this is a long axis of distal tibia, and this is an axis of calcaneum. And that gives us the idea about how much is the problem at the subtalar joint or below the ankle, not subtalar joint, but below the ankle. Coming to the last part, that's a treatment. The options we have is a non-operative treatment or a operative treatment. I'm going to focus mainly on the operative line of treatment, because non-operative treatment is just as a compensation. We can give a weight sole, but it does not correct the thing. It's just a compensation. So for the operative line of treatment, we have two options. The first is growth modulation, and the second is osteotomy. We cut the bone and correct the deformity. So let's understand the concept of growth modulation. This is a valgus deformity at the distal tibia. We put a screw like this. Already the case has been shown probably yesterday. So the same thing, like we put a screw on the medial side, we are reducing or stopping the growth of a medial distal tibial physis. So the lateral side will continue to grow, and over a period of time, the deformity will get corrected. So this is the deformity. There is a valgus deformity. This is how the screw has been inserted from the medial malleolus, a very easy procedure. And over time, the deformity gets corrected because the growth will take from lateral side of the distal tibia. And this is the final thing. We need to remove the screw. Now, one thing is very important, that the cause of the deformity is still there. So we need to keep them under follow-up, because there may be a recurrence of the deformity. And if it takes place, then we need to intervene again. The question is like, what about leaving it like this, keeping the screw? If we keep it there, then again, it will lead to overcorrection. So that is also not advisable. The advantage of this procedure is like, because it's a small procedure, on the third or fourth day, child can start walking as soon as the pain is taken care of, and there is no immobilization at all. So that's a very good procedure from the patient's perspective. The word of caution, the distal end is slowly growing. So don't expect a rapid correction. Usually the correction will take 2 years or so, depending on the amount of deformity. And the 3 years growth must be there. Then and then we can expect some correction. This becomes very important for some of the cases which we discussed, particularly that is in a female patient. Then they don't have adequate growth. Then in spite of doing a procedure, we will not get a complete correction. So this is one point which we need to remember. Coming to the osteotomy, Dr. Jasar asked about that, and this is what we need to understand. It's a wonderful procedure. On table, we get a correction. So it's very satisfying to the surgeon. The question which comes when we are dealing with the distal tibia or the supra ankle deformity, should we cut the fibula or not? And how should we fix? So let's see, this is a supramalleolar osteotomy. Let us understand like that. If this is a deformity, there is a valgus thing, we need to draw a line which is perpendicular to the tibia, the long axis of tibia. This is axis, the line which we draw perpendicular to the physis. So this is the amount of correction which is required. We take out, or before we take out the bone, we need to cut the fibula at the same level, because fibula will not allow the deformity to correct. So we take out the triangular wedge and then we correct the deformity. So this emphasizes that it's important to cut the fibula at the same level. Coming to the question about the deformity when it is below ankle joint, we try to, or we can correct it with the calcaneal displacement osteotomy. So if this is the deformity like this, in that case, we can cut the calcaneum and we can displace it and shift it medially so that it comes underneath the line of weight bearing. We can also carry out a calcaneal angular deformity, and in which we take out the wedge, we cut the bone and then we rotate the distal fragment and we put a graft in the gap. So these are the options available to us for correction of the deformity. So in short, the coroplan deformity, it can be at two sides. It's very important that we decide whether it is above ankle or below ankle. The X-ray helps us to identify where the problem is. Growth modulation has a role, very good technique, but it has a role in a very small number of cases. It's not a panacea. And if that is not possible, then we can definitely correct it with appropriate osteotomy. Thank you. Just, I would like to say that all my lectures are with Jaswinder, and if you need to go through any of the X-ray, just request him. He will share my presentation. I will be happy to share with you. So those who are taking pictures during the presentation, please request Dr. Jaswinder and he will definitely share my presentation. Thank you.
Hello, the next speaker is Dhiren Ganjawala. Oh, acha. Doctor.
May I request Dr. Sandeep Padia? Please come.
Yeah.
Dr. Hitesh Shah.
Yeah. Good morning. Yeah. So before starting about the foot and tibial hemimelia, I'll say the tibial hemimelia is exceedingly rare tibial deficiency. Because the talk is there, I am going to say that. And we are fortunate to have its deficiency of the tibial long bone is very less, because it's not very easy problems. So I'm going to give the rough idea about the foot deformity in a tibial deficiency. Whenever there is a tibia is absent, the medial side of the race would be absent. And whenever the lateral side of the leg long bone would be absent, like the fibula is absent, the lateral race would be absent. Sandeep is going to talk on the fibular hemimelia, so I'm not going to go in a fibular hemimelia. But its important aspect in fibular hemimelia, the clubfoot is exceedingly rare. Very commonly it will go in valgus and equino valgus and lateral lay deficiency. On the contrary to the fibular hemimelia, the tibial hemimelia, the foot deficiency is very, very different. It can go with the deficiency, it can go with the duplication, it will go with the triphalangeal term, it can go with the triphalangeal, 3 phalanx will be there.
So very different spectrum is there, though it is actually exceedingly rare. The deficiency is not very, very common to have a deficiency. But the main focus of the surgeon would be saying that whether he can salvage and do about reconstruction or he can do about ablative surgery. So the main focus is on the leg, not on the foot. If ankle and foot would not be the first priority of the treatment for the tibial hemimelia. So the priority of the reconstruction versus the limb ablation would be of the tibial hemimelia, whether it's a what type is there, type 1, type 2 and type 3. So that is very important. I will include that in the different parts of the talks on that. So by and large, the tibial hemimelia, there are the various classification, but not confuse that. We put a very, very simple classification is that whether the tibia is completely absent, whether tibia is partially absent, or whether tibia is the diastasis between tibia and fibula. There are the multiple classification is there, Kalamchi, Weber, Jones. I'm not going in detail. Common is that whether it's complete absent, partial absent, or distal tibia fibula diastasis. This is very, very simple to follow on that. What happened in case of the pendulum of tibial hemimelia moves? If you read the literature, whether you do the limb ablative surgery or limb salvage surgery, the people who are there from the complete tibial hemimelia will say very simple, we can do about ablation because quadriceps is, the tibia is forming the knee joint and ankle joint. If complete tibia is absent, the ankle is unstable, knee is unstable, and quadriceps is not working. So simple thing is that do about the disarticulation of knee, because it will be a single surgery and lead to the less cosmetic as well as the psychological problem to the patient and parents. If you do about reconstruction, it will require the multiple surgeries, and it is a very, very prolonged, and ultimately the child will walk with the brace, not about the prosthesis. The pendulum or the trends of the tibial hemimelia moves from the reconstruction to the ablative. So the reconstruction, it's initially described by the Putty and Brown in the literature, but then Loader said both of them doesn't work very well, and ultimately it require about the amputation. However, after that is a few population from the Japan and as well as the Europe, they said they don't accept the amputation. So they tried about the reconstruction. So there are the few articles came about the knee reconstruction and the limb salvage for that. But I'm not going in that detail. I want to just sensitize. It is the different spectrum of the limb ablative versus the salvage. So by and large, when there is a complete tibial hemimelia, when quadriceps is functioning and there is a flexion deformity is not severe, we can think about the salvage. Salvage means in tibia fibula reconstruction, fusion, and the Brown's procedure. But Brown's procedure will also have their own problem. So it's like that. It's a type 1 tibial hemimelia. Tibia is completely absent when there is a duplication of toe. There is a both side. There is a duplication of the mirror image duplication. It's called as a preaxial polydactyly. We can do about the reconstruction, and because the quadriceps is working, we can see the quadriceps is working. In this child, we have done about reconstruction. I will show you about that. And the child is standing because it's a quadriceps is working. Very few deformities there. We remove the extra rays on the medial aspect, the preaxial polydactyly, and the child is on the both side, not on one side. When the tibial hemimelia, again type 1, there is no functioning quadriceps. Quadriceps is not functioning. There is severe amount of the flexion deformity. There is no role of doing about the reconstruction. Again, Weber, Palais, as well as Dr. Vada has doing about reconstruction, but average number of surgeries require 8 to 10, and then the lengthening also will be really problematic if it is unilateral. So it's a simple surgery is do about disarticulation. When the complete tibial hemimelia with shortening of the femur or a PFFD, you can do about the fusion of the knee joint and amputate the foot. Then the put about the prosthesis like a knee disarticulation type, because it will be associated with the PFFD. What would be the treatment for the type 2 when there is a partial tibial hemimelia, where there is a proximal part of the tibia is present and where there is a moderate amount of the deformity is there, but no ray is missing? You do about a reconstruction in terms of the tibia fibula fusion and the limb lengthening. Like this child, where you can see on that the right side, there is a severe tibia, distal tibia was absent. We did about the tibia fibula fusion and do about the lengthening. We have the long-term follow-up. This child is quite good. When there is a partial tibial hemimelia with a severe shortening with the rays are missing, when there is only 1 or 2 rays are there, it's not a stable foot.
We can do about amputation at the Shyam's amputation or the below knee prosthesis we can put about that. So like this, where there is a glossally deformed with the only single ray is present. This is the example where there is the type 2 hemimelia where the only single ray is present. There's only one ray is there. So we can do about the amputation, tibia fibula fusion, and about do the Shyam's amputation, and the child can walk with the below knee prosthesis. Type 3 will be having the distal tibia diastasis where there is a tibia and fibula is fused and do about the limb lengthening later. That will be, I'm not giving example of that. But these are the overall by the type of the deficiency. But there are the more pattern would be there whether the tibia is completely absent with we associated without duplication. Without duplication means there will be 5 rays would be there without form elements, or it will be present with the duplication of the form element. It will be more than 6, 7 or 8 metatarsal and phalanges would be there, or that may be the partial tibial hemimelia would be present with the 5 rays or 6, 7, 8 rays with duplication or without duplication, or will be having with the tibial dysplasia. Depends, the tibia is dysplastic in shape. So first complete, incomplete or dysplastic, then say the without duplication or with duplication. We'll see about example like this is a dysplastic tibia. Tibia is trapezoid in shape, and we found that it's along with the trapezoid tibia there would be duplication of talus and the form elements. It's very, very common. Trapezoid, the duplication would be there on a pre-axial with the duplication of talus, and duplication of the fibular diamelia will be associated with the duplication of the calcaneum. So this is an example, the complete tibial hemimelia with the without duplication. We can see there is the medial side is absent, equinovarus is there, the great toe is shorter, but that all the toes are there, all 4 toes are there. And this is the X-ray, that's a pre-axial polydactyly where there is a with duplication, where there is a tibia is absent, but we can see the number of rays in the X-ray. You can see the 7 rays are there. That this is a hypoplastic metatarsal. The first ray is hypoplastics. This is the X-ray where there is a pre-axial polydactyly with the mirror image or the mirror image duplication. Exceedingly rare to have the duplication of fibula, that is called as the fibular diamelia. This is a case tibia is completely absent, but the fibula is double. Where there is a fibula is double, it will be common with the lateral rays would be duplicated. Lateral rays would be double calcaneum or sometimes double cuboid, and there is lateral metatarsal. It will be very, very common with the you can see here there's a single talus and side there are 2 calcaneum that will be present with the mirror image duplication of the polydactyly. Single part will be, central part is there, but it's a mirror image. Central is the first ray, laterally and medially both are the metatarsal. Duplication of calcaneum cuboid or a lateral cuneiform. That will be the image with the fibular diamelia, and there would be single talus. These are the clinical pictures of the fibular diamelia. What will you do then? A partial tibial aplasia, there will be normal toes, all 5 toes would be there, or the rays would be reduction. There will be reduction in a rays, or it may be sometimes would be duplication of the toes. We can see the duplication on the metatarsal type or a phalangeal type, or duplication of talus. We can see there will be double talus here also, or the fused talus. In case of the dysplastic trapezoid, the pre-axial mirror polydactyly will be duplication of talus with the duplication of the metatarsal would be there. Again, we can see the single calcaneum and double talus. We have dissected, fortunate enough to dissect the few cases which go on to the amputation. We see that endoachilles inserted more medially in here. Sometimes tibialis posterior would be the absent or would be passed superficial to the flexor retinacular tibial nerve, and the posterior tibial artery would be superficial to flexor retinaculum, and there will be abnormal tendinous structures would be present. Similarly, the same tendinous structure will be work as a tether, and if we by chance we go for the reconstruction, this would be the helpful. And these similar things were present by the arteriogram, because sometimes it will be tibial artery would also be the absence. So these are the implication for the reconstruction. I will end my talk on here because these are the important parts where we can see there would be 5 toes or more than 5 toes, or that may be absent toes in case of the tibial hemimelia. Thank you.
The next speaker is Dr. Sandeep Baidia, please.
Okay, so I am going to speak about fibula hemimelia. And unlike tibial hemimelia, in fibula hemimelia is much more reconstructible as compared to tibia hemimelia. But still, there are situations where you have to take a call, are you going to, reconstruct the foot, or are you going to ablate the foot, or are you going to do nothing? Even there are circumstances where you would do absolutely nothing. So I am not going to focus on the surgical technique. Okay, I am only going to focus on the decision-making process, and because that is what is most important for you. So fibula hemimelia, we all know it is a congenital deficiency with partial or complete dysplasia of the fibula. So it has been proposed that it has a vascular etiology. Okay, the blood supply to the growing lower limb in the fetus, that is affected, and therefore it is not just a problem of the fibula. It is not just the fibula that is affected. It is a problem of the entire lower limb. So you have a leg length discrepancy. You may have an associated congenital short femur. In fact, many times you do have a short femur associated with it. You have a knee instability, which is because of absence of the cruciate ligaments. You have a genu valgum because of hypoplasia of the lateral femoral condyle. Then you have a tibial shortening and deformity. And finally, the topic of discussion today, you have the foot and ankle deformities. So what do you have in the foot and ankle? So again, in the foot and ankle, there is a range of problems that you can have. You can have a ball and socket ankle. You can have an ankle valgus. Many times you do have a subtalar tarsal coalition, which is again malunited. So there is a coalition at the level of subtalar joint, which is malunited. Then you have an absent lateral raise, and the deformities, in terms of deformities, you can have either have a equinovalgus foot, or you can have even have a club foot in some circumstances. So a fibula hemimelia, the foot can come in various shapes and sizes. And because there is such a varied presentation, it is important that we classify them. And more importantly, the classification should guide us regarding the treatment to be adopted, the treatment modality to be adopted. Now, the earliest classifications that were described, these were described in the 1960s and 70s, that is the Coventry Johnston and Ashton Kalamchi. They basically were based on the percentage of absence of fibula. However, these classifications are not of much use clinically, because our decision making is not at all based on how much of the fibula is absent. It is based on something much more than that. So this was a more comprehensive classification, came out in 2003. In addition to the percentage of absence of fibula, what this classification, the Stanitsky classification, took into account is what is the orientation of the tibiotalar joint, is there a tarsal coalition, and what are the number of rays. But from point of view of treatment, the two classifications that are most useful according to me, the first one of that is the Birch classification described in 2011. And there are four things that the Birch classification took into account. How many rays are present? Is there an associated congenital short femur? What is the leg length discrepancy measured as a percentage of the opposite limb? And are there any associated upper limb anomalies? So how the Birch classification is useful in treatment decision making, we'll come to that in just a short while. But apart from that, the other decision, the important classification in terms of treatment decision making is the Pally's classification. Because if you choose to reconstruct that foot, the Pally's classification guides you as to what exactly is the reconstruction procedure that you are going to adopt. And we'll discuss this in a bit detail in a few minutes. So how do you make your treatment decision making? So there are mainly two main things that you need to consider. Are you going to reconstruct this foot, or are you not going to reconstruct this foot? And if you are going to reconstruct, how are you going to reconstruct? So the first question, to reconstruct or not to reconstruct, and the Birch classification gives you a good treatment algorithm for that. I have attached the chart over there, but to simplify things, let's see what are the Birch recommendations. And I find these to be very logical, okay, very logical and very practical. So the first step is differentiate between the reconstructible foot. So what is a reconstructible foot? Very simple. 3 or more rays is reconstructible. 1 or 2 rays is not reconstructible. So if the foot is reconstructible and the leg length discrepancy is less than 10%, you definitely should reconstruct that limb. That's the first rule. If the foot is reconstructable and the leg length discrepancy is more than 30%, you should not reconstruct. However, with a reconstructable foot and a leg length discrepancy between 10 to 30%, that is a bit of a gray zone. And here the decision making depends on multiple factors like the surgeon's skills, the available resources, the financial and the social situation of the family. That is perhaps one of the most important factor in our country. Non-reconstructable foot, how do you manage? So you have a non-reconstructable foot and the upper limbs are functional. In that case, you would do a Symes amputation and fit the child with a below knee prosthesis. On the other hand, if you have a non-reconstructable foot, that is only 1 or 2 rays, and the upper limbs are not functional, then the lower limbs, the foot might be useful in performing some activities, some prehensile functions of the upper limb, and therefore you should try to preserve the foot in that case. And in those cases, rather than doing a Symes amputation, just apply a simple extension prosthesis. So you preserve the foot and apply an extension prosthesis. And most importantly, in our country, take into account social issues. Especially if the child is going to need 2 or more lengthenings, are they going to be able to afford it? Where do they stay? Are they coming from a remote area? These all things have to be taken into consideration, and you have to discuss with the family. What are the non-reconstruction options? So I have mentioned that there are 2 options. So if the upper limb is not functional, you would probably preserve the foot and you would apply an extension prosthesis. And the upper limb is functional, then probably you would do a Symes amputation and apply prosthesis. There have been studies which have compared the results of amputation, Symes amputation and prosthesis versus extension prosthesis. And what they have noted is the amputation with below knee prosthesis probably has a better functional outcome as compared to an extended extension prosthesis. Now coming to the reconstruction options, and for here I have probably, in today's day and age, the go-to article is this one by Dror Pally. It came in JCO 2016. It is an extensive article, almost a 35-40 page article, in which all the reconstructive options, the surgical techniques have been described in great detail. I am not going to go into the surgical details. What I'm just going to tell you is the principles of treatment. So basically what you have to do over here is you have to identify all the problems. So talking about the foot and ankle, what are the bony deformities that can be possible? First of all, there is a distal tibia bowing that can be present. Then there can be an ankle valgus. At the subtalar joint, many times there is a collision, as I mentioned earlier, and this collision, most often it is malunited in a position of equino-valgus, but in some cases it can also be malunited in a position of clubfoot. Okay, so identify these, and these need to be corrected. Also, you have to release the tethering soft tissues. So what are the tethering soft tissues, main tethering soft tissues in case of a fibula hemimelia? You have a fibula enlarge. What do I mean by fibula enlarge? So the fibula is absent. It cannot be seen on X-rays. However, there is a thick fibrous remnant of the fibula which is still present over there. And what this enlarge does is it tethers the ankle and foot into a position of equino-valgus. So you have to correct a foot and ankle deformity. You have to excise this fibula enlarge. That is an essential part of the procedure. Peroneal tendons, many of these cases, they are short, tight and fibrosed, and they need to be lengthened or released. Gastrosoleus, again, it can be tight or contractured and it needs to be released. Now coming to the, type wise, what procedure should be done. So type 1 is basically a normal foot and ankle, and no procedure needs to be done for the foot and ankle. In type 2, Paley's type 2, this is a dynamic ankle valgus, meaning that the child does not have an ankle valgus deformity at rest, but on weight bearing, the child develops an ankle valgus. And here Pally has described what is known as the short procedure, which is the acronym for shortening and realignment of distal tibia relative to fibula. I would recommend you to go to the article and read this technique if you ever plan to do this. Type 3 and 4. So these have subtalar collisions which are malunited in either equino-valgus in cases of type 3 or in clubfoot position in case of type 4. So here you have to do what is known as the super ankle procedure. And basically it consists of supramalleolar shortening plus realignment osteotomy of the distal tibia, subtalar osteotomy. So this osteotomy is through the collision, through the tarsal collision. So just like you do a calcaneal displacement osteotomy, which has been earlier discussed, here this is an osteotomy through the subtalar collision or through the subtalar joint, which is not actually present in this case. And of course, you need to do the soft tissue releases along with that, mainly excision of the fibula enlarge. Just to give you a few case examples. So this is a child with a fibula hemimelia where you can see that there is a subtalar collision which is malunited in an equinovalgus position. What we did in this particular case is we did the superankle procedure, which is excision of the fibula enlarge. Then we did the tibia osteotomy, and plus we did the subtalar osteotomy and corrected that equinovalgus. This is a follow-up, and the child has later on undergone a lengthening, and the first lengthening has been done. He is around 7 years old, but he is going to need a second lengthening sometime in the near future. Another example, now this was a child who was almost 8 years old, never sought treatment before, came to us, and you can see that she is walking almost on the dorsum of the foot. The ankle is completely dislocated. Now looking at the position of the foot and ankle and also the social condition, the child is coming from the remote area. There is no point in preserving this foot and ankle. What we opted to do here is a Symes amputation. Okay. So to conclude, foot and ankle problems in fibula hemimelia can be varied. First step is identify which feet you're going to reconstruct, apply appropriate reconstructive techniques for these feet. Non-reconstructive techniques can have good functional outcomes if appropriately chosen. Thank you.
May I request Dr. Ritesh Pandey?
A very good morning to all. So I will be speaking about pediatric hallux valgus, and it is very important to realize that it has lot of differences from an adult hallux valgus, and we should keep in mind these peculiarities and treat these children accordingly. So we will discuss how they are different from an adult hallux valgus and how we should proceed towards its management. So hallux valgus is a lateral deviation of hallux and medial prominence of first metatarsal head, and the incidence is much more in girls with a ratio of around 10:1, and according to the age at onset, they can be congenital, juvenile, or adolescent. Radiographically, the hallux valgus angle is increased, and it can be grouped into mild, moderate, and severe types. Similarly, the intermetatarsal angle between the first and second metatarsal is also increased, and anything more than 9 degrees is considered abnormal. And contrary to the etiology in adults, in children, mostly they will be idiopathic. That is, the cause cannot be discovered. And in few cases, an underlying cause can be identified, of which neuromuscular and connective tissue disorders are most common. And then you have other less uncommon etiologies like post-traumatic or in association with flat foot or genu valgum. It is also important to realize that onset before puberty usually have an underlying cause, and one should look for that underlying cause. Whereas onset around puberty is mostly idiopathic and post-traumatic. So how is it different from adult hallux valgus? So the first important thing to realize is, in children, usually the joint, the first MTP joint is congruent. Whereas in adult, there is incongruity, which is giving rise to the deformity. In children, on the other hand, there is lateral tilt of the distal articular surface of the first metatarsal, whereas in adult that is usually not the issue. And this can be appreciated by an increase in the distal metatarsal articular angle and the proximal articular set angles. The other important difference is that the varus of first metatarsal can be because of a tilt in a medial tilt in the articular surface of the medial cuneiform. But more common in children is its association with metatarsus adductus, where the central metatarsals are also deviated medially. And in these cases, you won't get an increase in the intermetatarsal angle. Then there are other differences like a lesser deformity, smaller bunion. The joint is usually not arthritic, and you have a growth plate, which because of which there is risk of progression of the deformity. It limits the surgical options. There is remodeling potential and hence the risk of recurrence also. However, it offers you the option of growth modulation. So it is very important to keep in mind these peculiarities and not to treat the children similarly as adults. And the treatment can be discussed in two groups, that is before maturity and after maturity. Before maturity, conservative management is the treatment of choice, as the surgery has a very high recurrence rate, which is reported in literature up to 61%. However, early surgeries can be considered for syndromic and neuromuscular deformities in special scenarios if the conservative treatment has failed and the deformity is progressive, or if it is symptomatic and painful. And it consists of combination of interventions like bracing, stretching exercises, activity modification, footwear modification where you give wide toe shoebox, and orthotic inserts can be helpful if there is concomitant pace plainness. And different bracing protocols have been described, which depends on the age at treatment. Growth modulation is an attractive option in this age group. However, these techniques have not been widely used and it needs proper validation. And when chosen, it can be done in different ways, like you can go for percutaneous drilling of the lateral physis, or you can choose a screw epiphysiodesis, hemiepiphysiodesis. A double level hemiepiphysiodesis has also been described, which consists of intervention in the proximal phalanx and the base of first metatarsal. However, the results of this double level epiphysiodesis is equivalent only to the single level epiphysiodesis. So this was a case of a 10-year-old boy with hallux valgus, and a screw epiphysiodesis was chosen here, hemiepiphysiodesis. And at 2 years follow-up, we have satisfactory results. However, it is important to realize that the rate of correction is very, very slow, and it is around hardly 2 to 3 degrees per year. So you need to have enough growth potential remaining if you're going for this modality of treatment. After maturity, the treatment consists of definitive deformity corrections, and a number of procedures have been described in literature. However, there is no consensus about the single superior treatment. So I won't be going into details of all these procedures because of the time constraint. So they can be grouped into soft tissue procedures. Usually these are not done in children, and they can be added if you have an incongruent first metatarsophalangeal joint. Then you have different type of distal osteotomies, of which Akin osteotomy is widely described. It is done at the level of proximal phalanx. Then you have osteotomies in the distal metatarsal. Again, different types have been described. So these take care of the deformities which are located in the distal part of the foot, like in proximal phalanx or distal first metatarsal. And this distal M1 osteotomies, it corrects the lateral tilt of the distal articular surface, which is a peculiarity in children. Then scarf osteotomy can be done in the diaphysis. And then you have proximal osteotomies either in the base of the first metatarsal or in the medial cuneiform. In case of concomitant metatarsus adductus, you need to correct the deformities in the central metatarsals as well, because that will not allow the first metatarsal correction if it is left untreated. And then you have fusion procedures which can be done alone or in combination with an osteotomy, and it is ideally indicated for neuromuscular or syndromic cases, or if the joint is painful or arthritic. So as we can see, these isolated procedures are not self-sufficient, and they take care of only a part of the problem. So it is they are normally or very commonly used in combinations as per the case scenario. Also, the minimally invasive techniques are becoming more popular because they offer limited tissue dissection and less surgical time. So the current trend is to use a la carte approach, where a combination of osteotomies are chosen depending on what deformities you are facing in that particular case. So here is a stepwise approach. If there is distal metatarsal articular angle is increased, that is, the deformity is in the distal metatarsal, and you have a lateral tilt of the distal metatarsal articular surface, you need a distal metatarsal osteotomy. For the correction of M1 varus, you will have to add a proximal metatarsal osteotomy. In some cases, both these problems can be taken care of by the scarf osteotomy, which is in diaphysis, but it has again its own limitations. And if you are facing a concomitant metatarsus adductus, then the central metatarsal osteotomies also needs to be done. Then adjuvant procedures, they are not done routinely, but they can be added if the case needs it, like bunionectomy, soft tissue procedures, and a proximal phalanx osteotomy if you have hallux valgus interphalangealis. So this was an example, a 22-year-old female. We can see a hallux valgus and presence of metatarsus adductus with a almost normal intermetatarsal angle. So here the osteotomy of the center metatarsals were done, and the first ray deformity was corrected by a distal metatarsal osteotomy and Akins osteotomy. And these are the results after 9 months, showing a satisfactory correction of the deformity and healing of the osteotomies. So to conclude, this algorithm can be followed where all the cases receive a trial of conservative treatment, and if it fails, appropriate surgical procedure can be chosen depending on the age of the patient and the type of pathology. And take home message is, remember the anatomical peculiarities of hallux valgus in children. Conservative treatment is the first choice for younger children, though you can consider a growth modulation at this age if sufficient growth is remaining. Carry out a la carte surgery after maturity. Favor minimally invasive surgeries wherever possible. Fusions for neurological and syndromic deformities. And of course, you need to correct the concomitant associated deformities like pes planus, equinus, and genu valgum if present. Thank you.
Thank you. Now the house is open for the discussion on the deformity correction.
Any questions?
So I talked about may I ask Dr. Hitesh Shah regarding the congenital malformation of the ankle and subtalar joint. Sir, is there any role of genetic therapy in the management of congenital malformation?
Associated with the tibial hemimelia, it is very common to have a P1, T1X gene as well as the ZRS gene, but that is not common in therapeutic. That is only for diagnosis. So therapeutic, the gene will be on way. It's not At present, it is there, but it may be future.
Sir, have you ever tried a stem cell therapy in pediatric deformity?
I don't think so. It's a stem cell will have a role for the limb deficiency, because when there is a deficiency is already present on the medial half, there is anatomical structures are not there. I don't think so. Is there any role of the stem cell therapy for the limb deficiency at present?
Okay, thank you.
So Dhiren, you were talking about the compensatory deformity. So if you have a supramalular deformity, but it's long standing, you end up with a subtalar deformity. You mentioned it, but you did not tell us how you plan your correction in those cases.
So the question is about the compensation which is taking place. Yeah, fine. If it is there, then once we correct the supramalleolar portion, we have to take care of the portion below the ankle joint. Otherwise, like, we will not be able to correct the complete.
So you would correct both, or you would correct less on top? And
both.
Okay.
Any more questions before me?
My question for Alex Valgus, with Dr. Ritesh Pandey, that whether you need, when you do multiple metatarsal osteotomy near base, then whether you need any fixation or just you leave it.
Normally, we don't fix the central metatarsals because they are low energy osteotomies, and it usually heals very well without any fixation. And it gives you space to move them when you are correcting the first metatarsal deformity. And we don't normally go for fixation of the central metatarsal. The first metatarsal we do fix.
Sir, one thing. Is there any role of a spacer in a spacer in Alex Valgus? Yeah. Okay.
The toe spreader that you use in the initial stage. So it's like a spacer between in the first space.
So we don't have a talk from Dr. Sukalyan, and next we have a video session by Dhiren.
Fine. So like, I have a colleague, Dr. Kamlesh Devmurari in Ahmedabad. Whenever he attends any conference, he attends the conference with only one aim, that how many new surgical procedures I am learning from that conference. And when, like, we are together at the end of the conference, he will say that, Dhiren bhai, now I learned 6 new technique which I am going to apply. So I always look at that. He's very smart, and like, whenever he attends a conference, he has only one aim, to learn a new surgical technique. So I am sure that many of you would also agree with his philosophy, that we want to learn something new surgically which can help us to carry out the surgery. So to ask you the question, how many of you have done lateral column lengthening? Fine. So for remaining, I'm sure that I will try to make this procedure very easy. For you, you will learn some new surgical tips from the same. Let me tell you, I have a video, but first of all, I would try to explain you the theoretical concept. And then if time permits in this session or later on, you can see the video, but I would try to make it simple and easy to understand why and how we need to do this procedure. So the indications are flat foot deformity with the short tendoachelis. That's the first indication, a common indication. And those who are treating cerebral palsy children, for them, the planovalgus foot in cerebral palsy is the second indication. There is a slight difference in the surgical procedures in addition to that what we do, but the basic lateral column lengthening is same for both. Yesterday, Ritesh asked me the question, and the Sukalyan also asked me about, like, what about the tibialis posterior plication? Yes, when we are dealing with cerebral palsy child, we have to add that procedure along with the lateral column lengthening. So let's take a cerebral palsy, planovalgus foot deformity. This is what the classical appearance is. What are the components? This is going to be a revision, but still I'm explaining it again so that we understand when it comes to surgical procedure. The component is hind foot valgus. We already saw that in a previous picture. There is a hind foot equinus, midfoot break, forefoot abduction, and the forefoot supination. This forefoot supination is a new thing for those who are not familiar with this, and I will explain that why it happens and why we need to take care of that component. So let's say that this is a hind foot valgus, very clear, like when you look at the child from behind, the foot is in valgus. The hind foot equinus is very important. Like when we look at the lateral aspect, take a weight bearing x-ray and look at the x-ray, the talus is not horizontal, but it is slightly oblique. But when there is a short tendo Achilles, either flat foot or cerebral palsy, the hind foot is in equinus. So now talus is more vertically oriented than its oblique position. And there is a midfoot break as seen in this animation. So this is what the midfoot break is. So that's the third component. The fourth component is forefoot abduction. Again, we saw this yesterday. Now, lateral column lengthening and the additional procedures which we do will take care of all these components. So we see the foot as two columns, the medial column and a lateral column. On a medial column, we have 3 bones. On a lateral column, we have 2 metatarsal and cuboid. So medial column is long, the green one is long, the orange one is short. And this is how we correct. We cut the bone and then we correct it. Again, I am playing the animation. This is how we correct. It looks really well on the animation, and the same thing happens surgically also. So once we correct it, we put a bone graft in that. So now coming to the operative techniques. So these are the 2 incisions. One incision along the Langer's line. This is very good, but I prefer this incision which is along the peroneal tendon going towards the 5th metatarsal. This is, we are crossing the Langer's line perpendicular to that. It is not well cosmetically, but fine. It's easy for me, so I use this approach, but you can use the one which is described previously. So once we expose, the first structure which we see are the peroneal tendons, right? So we separate out both the peroneal tendons. Now we need to remember that we are lengthening the lateral column, so peroneal are going to become tight, and for that we need to lengthen them, because if we don't lengthen them, we will not be able to get the correction there. So for that we need to lengthen the peroneus brevis. We don't do anything to the peroneus longus. Look at the calcaneocuboid joint. It's not at all difficult. When we palpate with the periosteal elevator, we will be able to feel a gap or a gap, and that tells us about the calcaneocuboid joint. If you are not comfortable, use image intensification, and that will immediately guide you to that. Once we identify calcaneocuboid joint, actually we may not go or carry out dissection right up to there, but for those who are doing it for the first few times, please extend your incision by 1 centimeter or so and look at calcaneocuboid joint. Have a very proper understanding about the anatomy, so it makes things easy. Then we go 1.5 to 1.7 centimeter proximal to that calcaneocuboid joint, and we will be right into the sinus tarsi. It's easily identifiable area. You put your small lever, periosteal elevator or a lever into that area, and that will go very easily over there. If you want to excise the soft tissue from that area, you can excise, but it's not necessary to excise soft tissues from sinus tarsi. So yesterday also we saw this. Again, I would like to emphasize the point how our osteotomy travels. So this is the calcaneum. The lower part is anterior. The one which is on my side, left one, is a lateral side. So the osteotomy goes, so there are three facets: the anterior facet, medial facet or a medial facet, and then posteriorly there is a large posterior facet. And osteotomy is intra-articular osteotomy between the anterior and medial facet. This is how our osteotomy goes. So this is what like we have a periosteum elevator in the sinus tarsi, and then we look at the image intensification that our osteotomy is exactly at that point, and then we carry out a osteotomy like this. We can cut it with osteotome. We can use a saw also. It depends, like if you have a mini blade, you can use that. I use osteotome. And once we cut the osteotomy completely, we fill a giving way. So that is another important thing. Now, once you have cut the bone, don't go for distraction. We need to fix the calcaneocuboid joint, because if we don't fix it, there may be a subluxation of the calcaneocuboid joint take place when we are trying to distract the lateral column. So we need to fix it with a K-wire, which is passed percutaneously between the fourth and the fifth metatarsal. We just fill them and then use a K-wire and then we pass it. What I do at this point, I put a 1.5 centimeter osteotome in the osteotomy, and then I pass a wire. So when my K-wire touches the osteotome, I get a feeling that yes, I am exactly at that point, and that confirms that the K-wire is also in center. You can take help of IITV to locate, but this osteotome technique gives us so confidence that we are exactly at the right spot, or our K-wires are exactly at the right spot. We take out the osteotome. Now we have fixed the calcaneocuboid joint, so we are ready for distraction. And this is how it goes. Before distraction, we need to remember a few things that I will explain in a minute. Put a graft, and then we will going to complete the procedure. Extend the wire, and then we will pass the second wire. For distraction, there are various ways. Some people use two osteotome and then they try to open up. I have or some people use it, the lamina spreader, the small size lamina spreader. The problem with that is like it crushes the cancellous bone. Somehow our children's bone are not that strong enough. And when we apply this periosteum elevator, it crushes the bone. So instead of actually opening the osteotomy, it crushes the bone. So I have found this instrument, the one which is shown over here. There are two holes in that, and through that I pass the K-wire, one in the cuboid or in the distal end of the calcaneum, and other in the proximal part of the calcaneum. We use 2.5 millimeter thick wire, and then we bent it, and then we use this instrument. So with the help of K-wire, we will distract the osteotome. At that point, if it's not opening, then probably something is left at the medial aspect. So we need to use a small osteotome and cut the medial border of the calcaneum completely. Otherwise, it opens really well. So that is one thing, that if it's not opening, ensure that you have cut the distal end, which is not easily visible. So what we can do is like we distract a bit, and then we use osteotome to break the medial border completely. So once we do that with the help of the instrument like this, I have forgotten the name of this instrument. It's some interments. Yes, exactly. So we use that, and this is in place, and that is showing that now the osteotomy is open really well. So this is where we can see the gap. This is the gap which has been opened. We can use a lamina spreader also as an option. But the problem is like the previous instrument, with the distraction on, the osteotomy is completely open and you can insert your graft easily. While here it's a bit difficult because lamina spreader is in place and it does not allow the bone graft to be pushed easily. So once we have taken the graft, we can measure the distraction. Accordingly, we take a graft from iliac crest. I use in a lot of patients the fibula. I take a segment of fibula and then divide it into 2 pieces and try to fill that in the gap. So with the help of punch, we insert the graft completely, and then we extend the, we push the wire which is already there at the osteotomy level. We pass it through the graft and then in the proximal fragment of the calcaneum. Take IITV views and ensure that it is properly in the calcaneum. So graft, already we discussed that these are the options, particularly in cerebral palsy. If you are doing as a multi-level surgery, then a lot of times we use distal femur osteotomy as a technique, distal femur shortening osteotomy. So the same fibula can be used as a graft to fill in this osteotomy. We may not need to take a separate iliac crest graft. This will work. Fixation, usually the K-wire are sufficient. I don't go for a complicated procedures like fixing the plate. In literature, you will see a lot of patients, they are using plate and screws, but I'm very happy with 2 threaded K-wire, which is giving a sufficient hold. Staples can be used, but fine. As I said that I'm very happy with 2 K-wires. Now coming to the most important thing in cerebral palsy, this deformity has taken place because of the imbalance between the everter and the inverters. So once we correct it, the medial column will become lax. And on a medial column, there is an inverter, that's a tibialis posterior. So we need to shorten them so that the balance is created. That's the additional procedure which we need to carry out in cerebral palsy. So we shorten the tibialis posterior. So for that, we are looking at the medial side of the foot after correction. We make a small incision along the tibialis posterior, identified around 2 to 3 centimeter of tibialis posterior. And then we use a technique which I will explain you. If this is a tibialis posterior, we use a strong artery forceps like this, and then we rotate. So what happens, the tibialis posterior will enroll on the artery forceps and will become tight. So after rotating around say like 360 degree, there will be a shortening or the plication of the tibialis posterior. We keep that artery forceps in that position and take a suture and plicate it. We don't cut it, we just make it short, because our aim is to shorten it so that the extra length of tibialis posterior is taken care of. Now coming to the most important point, after the foot correction, we need to look at the length of the calf. We carry out cerebrals called test because always there is a shortening of the calf, either gastroc alone or both. So we carry out that checking after correction of the foot. Don't do it before, because unless and until you have corrected the foot, you are not going to assess the tendoachilles, or sorry, the calf properly. So at this stage, we carry out this correction. And now the most important thing is, like, once we have corrected this, we need to take care of the supination component. So I will explain you that part in a details so that you understand the concept of that. So now we are looking at the foot from behind. We have tibia, fibula, talus, and the calcaneum. We understood that hind foot goes into valgus. Now before that, we have a metatarsal with that. So what happens when hind foot goes into valgus like this? The forefoot also rotates with the hind foot, right? So something like this will happen. But patient cannot walk like this. So gradually what will happen? The hind foot will remain in valgus, but over a period of time, the forefoot will twist and will get corrected like this. Right? So now the compensation has taken place in the forefoot. Once we correct the hind foot and we have corrected it, so now the forefoot will follow and will go into a supination. right? So that's very important that in a long-standing cases, this is one of the component, and if you don't treat adequately or properly, then patient will go for a relapse. So this is one of the things that you have not corrected, one of the component of the deformity. So either we can use a wedge, but before that, this is what the picture at the time of surgery. Now look at this foot very carefully. The deformity has been taken care of. We are looking from top. This is long axis of leg, and we can see that this is what the forefoot is. It's in supination. So if we don't correct it, then child will be having a good heel contact, but the forefoot will be remaining like this. So for that, if you are not comfortable with the osteotomy, then you can put a wedge insole. This is one thing, that you give a wedge sole on the forefoot, because hindfoot is well corrected. Please remember that if you don't do it, you will lose the correction at hindfoot also in next few years. The better option is to go for a surgical correction, and for that we have a very simple procedure, that we cut the cuneiform bone and bring it down. So we bring the first metatarsal down, and for that let us understand this concept. We are looking at the foot from side, from the medial side. As we saw in this picture, the first metatarsal is higher compared to the fifth. So now if you look at the first metatarsal is higher, it's not touching the floor, while the fifth metatarsal is touching the floor. So what we do, we cut a wedge shaped bone from the plantar aspect and we bring it down. It's just a small simple procedure, and it corrects the forefoot alignment. We can fix it with K-wires. We can make a small staples out of K-wire and then fix it. So this is how, this is per-operative picture where we take out this wedge and then we fix it. And now you can see that this forefoot is also aligned with the leg. This is long axis. Now forefoot is perpendicular. And this is after fixation. Here it has been fixed with a small staple. You can use K-wire also. Post-operative management, once you have done surgery, now it's just a simple routine thing which we do, Bijlani cast. If you have done tendo Achilles lengthening or any procedures at that, we may extend it above the knee joint. So if we have done a calf lengthening, then we need to give above knee cast. We keep them non-weight bearing for 8 weeks, check x-rays at the time of removal of implant, and then we give a plastic arch support so that the abnormal loading can be prevented and the foot shape is maintained, and that we continue for 1 and 1.5 years. We are not going into the complications because on one side I'm trying to do the procedures, and so I don't want to make you afraid of that. But very rarely I have not seen a non-union subtalar fusion by iatrogenic extension of the complication. You can do that. Under correction is one of the things, because we are not really strong or like confident in lengthening the foot, and we may end up with under correction. So the take home message is lateral column lengthening improves the biomechanics, and definitely it helps us in gait improving. Plano valgus has a 5 component. The 4 components are very easy for you to understand, but the forefoot supination is the 5th component which we tend to neglect and don't operate. All components needs to be dealt with. Then and then your foot will remain stable for a period of time. And please remember that this surgery has a limitation. For a severe deformity, it does not work. So in that case, we need to go for more extensive procedure like triple fusion. So with that, I wish that you are able to do this procedure confidently. If you have any question, please take this presentation from Jaswinder. Or if you want to see a video, please let me know. I will share that video with you. Thank you.
Basic difference in terms of function, you do this osteotomy more posteriorly in the calcaneum and do a varus and a translation.
So something like the
One
displacement
part of
osteotomy.
yeah.
Okay, so this is basically is correcting the deformity at the subtalar joint. So this is not a compensatory deformity; it's a correction deformity. While the one which you are talking, which Sandeep also discussed and I also discussed in the previous lecture, we are not doing anything at the subtalar joint, and we are compensating the things, and then we are improving the things. So the subtalar joint remains in an abnormal position, but we are correcting it three-dimensionally. Yeah, extra-articular.
In the words of Moshka, the calcaneal lengthening osteotomy is a Salter osteotomy, whereas the calcaneal displacement osteotomy is the Chiari osteotomy. It is like a salvage.
That Dr. Mosca says calcanopedal block, and he always describe it like that. Actually, what
You should call it the Bernie's osteotomy.
Because he explains on acetabulum pedis that concept actually. So any more questions? So that was wonderfully presented by Dhiren sir, and it's time to felicitate our chairpersons. Dr. Hitesh sir, please do the honors. Dr. Nand Kumar sir, please. Dr. Dinesh sir. Dr. S.P. Gupta sir. And Dr. Ravi Shankar, please. May I also let everyone know that whatever lectures and the whole course is being also streamed online on the OrthoTV. So if someone has missed something and he wants to go back and see, everything is available on the OrthoTV. So we are recording it. We'll take a break now for 10 minutes. It's for a small tea or whatever you want. And then we'll come back for our last session, the theoretical session. Thank you.
And we don't want any money from this.
Good afternoon, everyone. My best wishes for a very successful pediatric. Good afternoon, everyone. Good afternoon, everyone. My best wishes for a very successful pediatric foot and ankle conference that is to be held in Patna over the next 2 days under the aegis of the Pediatric Orthopedic Society of India. As our specialty becomes popular across the country, we realize that there is a need for developing subspecialty meetings, CMEs, and conferences on various aspects of pediatric orthopedics, including pediatric trauma, bone and joint infections, hip pathologies, and one which is being conducted today and tomorrow, which is on the pediatric foot and ankle. I must commend the organizers led by Dr. John Mukhopadhaya and the organizing secretary, Dr. Jaswinder, for taking the impetus to develop this 2-day meeting, which is dedicated to pediatric foot and ankle pathologies. As the president of POSI, I wish you all the best for this conference, all the best to the organizers and to the attendees for a great learning experience. Thank you very much. Good afternoon, everyone. My best wishes for a very successful pediatric foot and ankle conference that is to be held in Patna over the next 2 days under the aegis of the Pediatric Orthopedic Society of India. As our specialty becomes popular across the country, we realize that there is a need for developing subspecialty meetings, CMEs, and conferences on various aspects of pediatric orthopedics, including pediatric trauma, bone and joint infections, hip pathologies, and one which is being conducted today and tomorrow, which is on the pediatric foot and ankle. I must commend the organizers led by Dr. Mukhopadhaya and the organizing secretary, Dr. Jaswinder, for taking the impetus to develop this 2-day meeting, which is dedicated to pediatric foot and ankle pathologies. As the president of POSI, I wish you all the best for this conference, all the best to the organizers and to the attendees for a great learning experience. Thank you very much. Good afternoon, everyone. My best wishes for a very successful pediatric foot and ankle conference that is to be held in Patna over the next 2 days under the aegis of the Pediatric Orthopedic Society of India. As our specialty becomes popular across the country, we realize that there is a need for developing subspecialty meetings, CMEs, and conferences on various aspects of pediatric orthopedics, including pediatric trauma, bone and joint infections, hip pathologies, and one which is being conducted today and tomorrow, which is on the pediatric foot and ankle. I must commend the organizers led by Dr. Mukhopadhaya and the organizing secretary, Dr. Jaswinder, for taking the impetus to develop this 2-day meeting, which is dedicated to pediatric foot and ankle pathologies. As the president of POSI, I wish you all the best for this conference, all the best to the organizers and to the attendees for a great learning experience. Thank you very much. Good afternoon, everyone. My best wishes for a very successful pediatric foot and ankle conference that is to be held in Patna over the next 2 days under the aegis of the Pediatric Orthopedic Society of India. As our specialty becomes popular across the country, we realize that there is a need for developing subspecialty meetings, CMEs, and conferences on various aspects of pediatric orthopedics, including pediatric trauma, bone and joint infections, hip pathologies, and one which is being conducted today and tomorrow, which is on the pediatric foot and ankle. I must commend the organizers led by Dr. Mukhopadhaya and the organizing secretary, Dr. Jaswinder, for taking the impetus to develop this 2-day meeting, which is dedicated to pediatric foot and ankle pathologies. As the president of POSI, I wish you all the best for this conference, all the best to the organizers and to the attendees for a great learning experience. Thank you very much.
So I welcome you back. May I start with our last session, which is after that we'll be starting with a hands-on workshop. So for the chairpersons, may I invite Dr. V.K. Sinha, sir, please, on the dais. Dr. Rajat Charan, sir. Dr. Praveen Sahu, sir. And Dr. Chandan Soni, sir, please. Hi. And the next speaker is Dr. Saurabh.
Hello. After the tea break, we are starting with the miscellaneous session, and Dr. Saurabh Chaudhary will speak about the child with foot pain.
Good morning, everybody. So the topic allotted to me is approach to a child with foot pain. That's a very broad topic and it encompasses a lot of disorders. I'll not be talking specifically about trauma cases that has been covered, and also about majorly about the deformities that I think we have discussed at length yesterday. We'll be discussing about certain case scenarios which are less commonly seen, but being pediatric orthopedic surgeons or being orthopedic surgeons, oftentimes we are referred cases by the pediatricians because the patient predominantly has a musculoskeletal complaint. And it's good to know, sometimes necessary to know which cases are pure core orthopedic cases and which cases you need to refer or work up in a different way. So non-traumatic causes of foot pain are like many. There's a huge list, and if at all you are faced with a patient who complains of foot pain, you may have a mind-boggling list of conditions which come to your mind. But in any case scenario, what we automatically do is we try to categorize that particular patient into some kind of etiology. And it's useful to know the conditions which are arranged in categories based on the cause of the problem. So these are the various etiologies which may present with foot pain. So the history, sometimes if it's a young child, the history is non-existent. You have to rely on the history of the parents, which may or may not be very useful, and often it is garbled. We have to make sense of what they are speaking, separate the grain from the chaff, and try to make sense of what the real issue is. So going to the history, there are a lot of questions that we need to ask. Onset of foot pain, any specific injury which was there, location of the pain in the foot, is it involving one side or both the sides? What kind of pain is it? What kind of factors aggravate it or relieve it? Any swelling or redness or warmth has been noticed by the parent? How does it impact the daily routine or the play? Any foot problems in the past? Has he had any similar issues in the past? How is the pain in the morning or the evening or the night? And how does it respond to analgesics? And if there are any systemic features are there, like fever or abdominal pain, any other joint swellings, any family history, and loss of appetite and loss of weight. So basically from all these questions, we want to ascertain whether this is an acute issue or a chronic ailment, whether one or more joints are involved, and if there are systems other than joints which are involved. So, these few questions you should be able to answer by the end of the history, and how severe or significant it is. Usually the children will like to play. If the play is affected, then you understand that the problem is significant and you should be prepared to investigate further, even if the lab investigations and x-rays are normal. Examination begin with general condition, whether the child is sick looking or looking active. Always check for pallor, rashes, skin lesions, nail changes. You look at other joints proximally. You look at the upper extremities and the spine. You look at the gait of the child, standing and sitting alignment of the spine, and the Beighton score. Locally, we look for swelling, redness, sores or callosities, overall shape of the foot, and any undue prominences if at all present. The foot is largely palpable, which is a good thing. So it's very useful to know the surface anatomy of the foot, where all the bony prominences, what all bones they represent, which tendons they represent, and if needed, we need to activate those tendons and stress them and check whether the tendon is painful. Labs usually in a typical case are not very useful. Routine tests, CBC, ESR, CRP is always done, occasionally vitamin D and alkaline phosphatase. Selective cases based upon the history or the kind of presentation that a person has, you may have to do antibodies, ANA, HLA-B27 and other markers. Imaging, again, X-rays are essential. Other imagings are required in particular cases. So this is a very didactic approach to what we we may discuss academically, what causes can be there, what history and examination and all that. But in clinical practice, we don't go by this approach. We usually try to fit the patient into a particular kind of clinical scenario and then do a selective examination and selective investigation. And if at all we don't get an answer, then sometimes we go back to the examination and labs again. So I'll just discuss briefly about certain clinical scenarios which are not discussed in pediatric orthopedic meetings or general orthopedic meetings. The first is the inflammatory arthritis, GIA or various other conditions are labeled into this. This is usually a child who has pain for more than 6 weeks. One or many joints may be involved. There may be significant early morning stiffness. Now the child or the parent will not be complaining of stiffness in the morning. What they'll be saying is the child does not is very reluctant to get out of the bed in the morning, and it takes about 1 to 1.5 hours for the child to be more active or start playing and all that. Occasionally the child may have some abdominal pain, his sleep may be disturbed, he may have rashes, fever, red eye or burning micturition. So child is crying while passing urine, or any history of these kind of loose motion or burning micturition in last 2-3 weeks. Labs may show a moderately high acute phase reactants. RF anti-CCP typically not very useful. ANA occasionally is raised, and HLA-B27 is occasionally required. So I must emphasize it's a diagnosis of exclusion. You have to rule out other causes or more significant or severe causes like infection before you label a child as a case of JIA. Child with rash and abdominal pain, think of HSP. Child with rash and sick looking child, he may be having Still's disease. So these are just some things that you need to bear in mind. And JIA can present with multiple clinical pictures. So it may be a POSI articular, it may have a picture similar to adult onset RA. It may be having systemic features, it may be associated with enthesitis or spondyloarthropathy kind of picture. The second clinical scenario is infective. Usually the symptom duration will be very short, accompanied by fever, and child is refusing to bear weight. This is something that we need to, we should be alert that it may be indicating infection. There will be swelling, redness, and localized tenderness, very high ESR CRP. X-rays may be normal in the initial stage. You may have to resort to ultrasound or MRI to get the diagnosis. And usually the foot is not a very common site for septic arthritis. So if at all you see any sepsis which is there localized to the foot and it's not secondary to some thorn prick or something, then you must think of immunocompromised status. You may have to rule out systemic infection, endocarditis and other things. Neoplastic is another broad category. Usually the pain is of weeks or months duration. Pain is constant and progressive. So pain is unrelenting, or pain is always there. It's not like some days the patient is fine and some days the patient has severe pain. Location is fixed. X-rays may be normal in the initial stage, but if the pain is persistent and it's on a fixed location, you may have to opt for advanced imaging even if the X-rays are normal. Counts will be normal. Alkaline phosphatase and peripheral smear are sometimes required if at all we are suspecting systemic features also like back pain and loss of appetite. Especially leukemia. Leukemia can present with foot pain, leg pain or back pain. So that is something that you need to bear in mind. Child will be sick looking and he'll have some back pain and he will be referred to you from the pediatrician. Always bear in mind it may be something else. If the counts are low or the peripheral smear is showing some atypical leukocytes, that clinches the diagnosis. Certain localized bone tumors, Ewing sarcoma, giant cell tumor of the tendon sheath. These are all possibilities that you have to bear in mind if the problem is in a specified location and the pain or the symptom is unrelenting. Now, often growth-related pains are very commonly presenting to our clinics, and sometimes they are overdiagnosed also, but it's useful to know what the typical patient is. Typically, the patient will have pain in the legs, very less commonly in the foot, and it will be episodic, severe pain. Child will be crying in the pain, especially in the night, or it is worse on certain days where the activity has been more. And he'll be absolutely fine in between the episodes. So this is something which tells you that it is growth-related pain, because between episodes, the child should be playing well, eating well, sleeping well. There should not be absolutely any complaint in between the episodes. Overuse injuries, again, the history will probably tell us that there is a recent increase in activity, or certain specific activities have started. Issues with footwears, specific site, again, and if you examine, usually you'll find a spot as a tender spot, and usually it responds very well to a brief period of rest. Always check for Beighton score in these kind of patients. Osteochondrosis, again, is a very broad category. Usually, again, it's a diagnosis of exclusion. The site will be specific. It may be related to activities. No inflammatory signs will be there locally, and it usually responds very well to rest. There are many of them described, but the commonest ones will be Sever's disease, which is in the calcaneal apophysis, Iselin disease, which is there in the base of the fifth metatarsal, Freeburg's occasionally in the second, third, or fourth metatarsal heads, and Kohler's, which is of the navicular. They all respond very well to a brief period of cast or immobilization. So the take home is, if at all there are more than one joints involved, always look for rheumatology consultation. If there are systemic features, refer back to the pediatrician or get a pediatric consultation. Always differentiate arthritis from arthralgia. And if there is a persistent one joint or one region pain, try hard to disprove infection or neoplasia. You may have to opt for an MRI right away if the pain has been there constantly and the patient is in significant agony. Thank you.
Thank you very much, Dr. Saurabh Chaudhary, for broadly elaborating the painful foot. Next speaker.
Dr. Hitesh Shah. He'll be speaking on postural deformity of the foot.
Yeah, good morning. After we have this talk should be the first rather than the last, but not the least, it should be discussed. So why it is important to understand about the postural deformity of the foot, because we need to differentiate between is it actually the benign postural deformity, or is it the pathological, or we are missing some pathology. So today's the foot and ankle, the deformity of the postural deformity is very common to have a calcaneo valgus, metatarsal adductor, or a postural clubfoot, or it will be also having in case of the children, as yesterday we discussed, the flexible flat foot. These are the very common deformity. So what is needed, what the orthopedic surgeon or the trainee or the pediatric orthopedic surgeon should know about that, there are the common deformity, and how to differentiate from the physiological from pathological. That is the main part, because the name itself says a postural means it's just required benign observation, is just required to have a serial follow-up. So what is needed for the deformity? As I said, there are three common deformity. It's a calcaneo valgus, that is a talipus calcaneo valgus, the postural clubfoot, or sometimes it's a metatarsal adductors, and the plano valgus due to ligamentous laxity is very common in the children. So these are the three different heading I'm going to talk on that. So first, let us start with the calcaneo valgus. What is a calcaneo valgus? When the child is born, there would be full dorsiflexion of the ankle present. The tibia and foot can be touched together. So if the orthopedic resident or even the orthopedic surgeon would be called from the NICU, when such and such child has been born and there is a deformity of the foot, First question we need to ask, is it benign or is it a pathological? Whether it's a benign means, is it a postural calcanevalgus or is it something different? So very commonly we can have a differential diagnosis is the vertical talus or the congenital posteromedial bowing, or it will be having in few cases of the fibular hemimal a limb deficiency, where we can find out about the postural or the benign or actually pathological calcanevalgus. How to differentiate between the both? Whenever there is a deformity is at ankle, it will be passively fully correctable. If we can bring to the neutral or overcorrect, it is most likely to be postural. Second, there are all toes would be present. Like if you see in this child, all 5 toes are there. Any ray of missing, any ray, whether the medial or lateral ray, it will be always associated with the limb deficiency. So it will be fibular hemimelia or any other deficiency. And the third also important, the bowing of the tibia. Where there is a tibia is bowed, very commonly the postural, I will show you the photographs on that. That's a tibia is bowed, then that would be associated like a posteromedial bowing. Why need to differentiate between postural and that? The natural history of the postural deformity is very, very different than the other part. So as I said, the first and foremost, you need to bring that to the neutral. If you can bring back to the neutral or the overcorrect, it would be postural deformity. It will be all the crease would be around the medial side, lateral side, multiple crease would be present. Do not forget to examine the hip if you have the ligamentous laxity or the associated with the calcaneovarus or metatarsal adductors. Always examine the hip, okay? Because most of the time you are called to see about the foot deformity, but you need to examine about the hip and spine. Why? Because that may be the secondary to the spinal deformity or the spina bifida. So always examine the spine then the hip before labeling as the postural deformity. Then the pathological, when there is a calcaneovalgus is there, there would be rocker bottom. Yesterday we have discussed the full, but they always see about the sole and see whether it is the planovalgus or is it rocker bottom foot is present, is a differentiate between the vertical talus. As I said, if the ray is missing and going in a calcaneovalgus, that would be associated with the fibular hemimelia very commonly in planovalgus foot, or it would be associated with the bowing. If you see the bow, there is the bow, the medial apex and the posterior apex, that is called as the congenital posteromedial bowing of tibia. That are the 3 important differential diagnoses between the calcaneovalgus. What is required? You need to keep in the observation, passive stretching, and few case, extreme case of the calcaneovalgus will require about few casts. There will be the few casts like a clubfoot. You need to stretch for the couple of weeks and just go about observation. So whenever doubt, you have to keep this child into the follow-up. Second entity, the postural clubfoot. So very, very common we can see about the clubfoot because of the package that you see there is a mild forefoot adduction is present. But what is different between the rigid clubfoot or the postural deformity will be different. Full dorsiflexion would be present and there would not be any spurious correction like we see yesterday. There is the hindfoot equinus is present when the empty heel sign is present. You can see about the multiple crease across the ankle on the posterior aspect. Number 1, you cannot have empty heel sign, and the third, full dorsiflexion is possible. These are the 3 important marks that you can differentiate between the postural clubfoot and the rigid clubfoot. So if you see that multiple creases are present, there is a looks like the forefoot adduction and the varus. But if you can do about the dorsiflexion, patient can able to passively, it can be brought under the overcorrection on the either side, the both side. So you can see there is the postural deformity, not actually the rigid deformity. Another example, there is you can looks like the cavus is present. So there is a equinus, but we can able to do about that. It's a good amount of the dorsiflexion is without doing any casting, the first presentation. So there is a difference between the rigid clubfoot and the postural clubfoot. All the component would be present and that would be rigid, not passively correctable in rigid clubfoot, because deformity is in the postural. It is not correctable at all in case of the rigid clubfoot, while it is fully correctable in case of the postural clubfoot. And the third important differential point is that a multiple crease would be present on the posterior aspect than the deep posterior crease is present in case of the rigid clubfoot. Why we need to differentiate? Because The clubfoot is a spectrum of deformity. It starts from the postural to rigid. It may be also having idiopathic or a non-idiopathic, is having spina bifida, to having multiple congenital or multiple syndromes. That is a multiple syndrome. And before labeling about the postural clubfoot, you need to do about thorough examination of every single system. Okay, don't say we have learned that passively it's correctable, that means it's postural clubfoot. Always examine the all other system before say labeling as a postural clubfoot. And one important example, the last week we have seen the child like this, it's labeled as a postural clubfoot, but it is actually the case of the severe sacral agenesis. This is a type 4 Renzo type, where lumbar spine is, the lumbar L4, L5 is missing, and different part is also missing. And thorough examination is needed to find out the prognosis of this child is different. It doesn't require serial manipulation and casting, because child is not having the neurological intact. It's the lower of the, it's a Buddha-like position, is not getting corrected, and unlike to get it changed with the plaster or any other intervention. But in short, the postural clubfoot require just manipulation by the parents, and few cases where deformity is persistent after few weeks, it's required about the casting, but it doesn't require about bracing in long term. The third, that's a pes planus. Yesterday it is described in a great detail, like a flexible flat foot. The Sandeep has described into that. So I am not going quickly. Why you need to know about the flexible flat foot? Because it may be varies from the cause to cause, including hyperlaxity to tibialis posterior dysfunction, or sometimes because of the obesity, and it may be also a pathological in terms of the tendo-achilles contracture, the subtalar coalition, or a tarsal coalition, or accessory navicular. So we need to check about the laxity, whether patient has got gross ligamentous laxity, whether the child is having obesity, or because of the shoe wearing technique, whether the child started use the shoes very early. Yesterday, Sandeep has described about Jack test will differentiate between the flexible and rigid. And then another test is the toe weight bearing, where the tiptoeing the arch is appearing. That is a flexible flat. So actually they consider it to be as a physiological. But always examine the ankle. There is a limitation of the dorsiflexion, give idea about the tendo-achilles contracture. Always examine the subtalar, the mediolateral, the inversion and eversion. If there is range of motion is restricted, give idea about underlying the tarsal coalition. Always examine the metarsal. If metarsal is restricted, it will give idea about that tarsal coalition in metarsal plane. So I'll conclude my talk in that we must differentiate between the postural deformity with pathological. Always rule out the pathological before labeling at the postural clubfoot, and it's necessary to detect this postural clubfoot or a postural metatarsal adductors or a postural calcaneovalgus or postural flat foot, because that will lead to the unnecessary anxiety to the parents. Thank you.
Would you like to continue with your another talk? Would you like to continue with your another talk? Now may I request Dr. Sandeep Vaidya to present his case.
Okay, so office orthopedics will continue with the conditions that we see, the common OPD conditions, and idiopathic toe walking is another common condition that we see. So this is a brief outline. First, I will talk about the definition of idiopathic toe walking. When should you label a child as an idiopathic toe walker? What is the natural history of this if left alone? And if at all you need to treat, then what are the various treatment modalities with their outcomes? So what is idiopathic toe walking? So it is a true equinus gait, meaning that the ankle is in equinus. The initial contact in the stance phase, it is on the toes rather than being with a plantigrade foot, it is on the toes. And all three ankle rockers are affected. The most important point is to label a child as an idiopathic toe walker, you have to rule out any underlying pathology. So it is idiopathic in an otherwise healthy child, and it is a diagnosis of exclusion, which means essentially that you have to examine the child as a whole. You have to examine the entire neurological system, the musculoskeletal system, and you have to rule out underlying cerebral palsy, Duchenne muscular dystrophy. Autism spectrum disorder is one condition which does give rise to toe walking, and here it's a very troublesome and very frustrating condition to treat, toe walking in an autistic child, Here, the cause of toe walking is sensory disturbances. So what happens is when the child places his entire foot on the floor, he gets, lots of sensory impulses, and to avoid those sensory impulses, the child is toe walking. This can be a bit of a frustrating condition to treat, and this requires sensory integration therapy and not your regular physiotherapy. Okay. And the overall incidence of idiopathic toe walking is estimated to be around 5%. So once you have ruled out all the pathological conditions, should you label every toddler who toe walks as an idiopathic toe walker? So there are stages of ambulation. A child first starts walking with what is known as tilted leg shuffling. Then he starts cruising around by holding onto furniture. And then finally, the normal gait, that is the heel toe gait, develops, where there is at the initial contact, there is a heel strike, then there is a midfoot contact, and finally there is a toe off. So this is the natural what happens in the the development of ambulation. What is important is that in the first two stages of ambulation, the child may tiptoe. This is normal. This is normal what I'm talking about. So that essentially means that toe walking gait is a normal variant in the intermediate stages of motor development of a child. So if in the first two stages a child is toe walking, that cannot be called as an idiopathic toe walker. That is not pathological, that is physiological. Something like physiological bow legs. Physiological bow legs till the age of 3, it is normal. Similarly, this physiological toe walking should disappear by the age of 18 to 24 months. So to label a child as an idiopathic toe walker, the child should be more than 18 to 24 months. What are the causes of idiopathic toe walking? Frankly, the causes are not known, but the causes which are proposed are: number one, genetic, increase in type 1 muscle fibers, sensory integration deficit, which I mentioned, very common in autism spectrum disorder, and early use of infant walkers. That has been proposed to be one of the causes of idiopathic toe walking. Clinical presentation, so mainly the parental concerns are cosmetic concerns and social concerns, and also the parents would complain of frequent tripping and falls. What do you see on clinical examination? Simply you may see tight TA with restricted ankle dorsiflexion. But as I come later, in some cases that may be absent. So you may have a good ankle dorsiflexion even in a child who is walking on the toes. Now, what is the natural history of idiopathic toe walking? And here there are two distinct courses. If the child does not have a restricted ankle dorsiflexion, that is, the child does not have a tight TA, in such cases, spontaneous resolution of toe walking has been noted in 60% cases by the age of 5.5 years and 80% cases by the age of 10 years. No significant functional disturbances or pain or deformities have been noted in these children. So this I'm talking about children who do not have a TA contracture, who have an unrestricted ankle dorsiflexion. On the other hand, children who have a restricted ankle dorsiflexion, they frequently complain of pain, falls, and psychological consequences. And these children, they warrant early intervention. So now finally coming to what interventions can be offered. So the child is now more than 18 to 24 months. You have determined that he is an idiopathic toe walker. Now what can you do? In the young children there are no limitations of ankle dorsiflexion, you generally first go for the conservative line of treatment. However, in older children where there is an established TA contracture, where the ankle dorsiflexion is not possible beyond neutral, in such cases, most of the cases, surgical treatment is needed. Conservative treatment does not succeed in stretching out the TA contractures in many of these cases. So what are the conservative treatment that you can offer? Now, so therapy, that is the first line of treatment. So most cases that come with idiopathic toe walking, we refer to the therapists who have different modalities by which to treat them. Then orthosis. So there are some studies which have reported the beneficial effects of AFO in children with idiopathic toe walking. What can we as orthopedic surgeons do in such cases of idiopathic toe walking? On the conservative line, if the therapy and orthosis are not working, then we can do serial stretch casting like what we do in CP. And there are also reports where they have used botulinum toxin with stretch cast. So that is injected into the gastrosoleus. So that has there are reports regarding this as well. What are the surgical modalities? And surgical modalities are needed in children who have an established TA contracture and who are not responding to conservative line of treatment. For these cases, you need to lengthen the gastrosoleus. Again, how do you lengthen the gastrosoleus? That depends upon the degree of your tightness and upon the results of your silver scale test. So that Dhiren sir has already described in detail as to what are the surgical interventions that you can do in case of TA contracture. If the silver scale test shows that only the gastrocnemius is involved, then you can do a Barker's or Vulpius gastrocnemius recession. However, in cases where there is the silver scale test shows that gastrosoleus both are involved, here you may do a Hoke's or a white slide lengthening. TA lengthening, tenotomy, that is, complete tenotomy is not recommended in this situation. The aim of your surgical intervention should be to achieve at least about 10 degrees of dorsiflexion. Outcomes, frankly, this is not a very well-studied condition, and outcomes of interventions are not very clear. There was one study in 2013 where they attempted to study it was a meta-analysis actually, where they studied the results of serial casting versus Botox with serial casting, and the results of this meta-analysis were inconclusive. They could not come to any conclusion. What is my treatment protocol? So when the child first comes in, I refer to physiotherapy. After an adequate trial of physiotherapy, the child is not responding, I go on to AFOs. Injection botulinum toxin is the next step. This is especially in cases where I can, with sustained pressure, get the the ankle to some amount of dorsiflexion. So if the therapy and AFOs fail, then I would resort to injection botulinum toxin. But surgery is required in established gastrosoleus contractures where the first 2 lines of treatment are failed to give the desired outcome. That's all from my end. Thank you.
Can I invite
Yeah, good morning, and then this will be the last talk. The talk was given that many things, macrodactyly, osteochondroma, osteochondrosis, and foot and limb deficiency. Foot and limb deficiency is already covered, so I'm not going to repeat the fibular hemimelia and tibialar hemimelia. So I'm going to talk on the macrodactyly. The macrodactyly is nothing but the enlargement of the toe or the ray, enlargement of the phalanx, maybe distal phalanx, middle phalanx, or a proximal phalanx, or maybe the ray, along with not only the enlargement of the rays, there is a length and the width of the ray would be more. That is a macrodactyly. The macrodactyly is one of the frustrating condition for the parents because it cosmetically looks ugly. And it is also the frustrating condition for the orthopedic surgeon because there is no consensus for the treatment for the macrodactyly. So I'm going to talk on the broadly how should we approach the case with the macrodactyly, and there is not a single treatment or the single protocol. There are multiple options to treat with that, and whenever it is needed, we can use the optimal treatment for the macrodactyly. So I'm going to talk on that, the issue with the macrodactyly, what are the goals of treatment, options, and choice of option with this few case example. As I said that the macrodactyly would be the enlargement of toe. It may be isolated with a single toe or it may be associated with the multiple toes. We can see about the first picture on above, the top would be only the one toe is enlarged, and second picture we can say grossly the enlargement of the second and third toes. But it's not only the enlargement of the toe, the length and the width of the foot is also the very different. So if the width and the length of the toes would be very different, the parents usually complain that the same size shoes would not be fitted for the both sides. So that would not be the only cosmetic problem. This is a grotesque looking the foot, and that is not acceptable in our society also. There is a very commonly associated with all the syndrome, but whatever syndrome is there, whether it will be associated with the neurofibromatosis or hemangioma or lymphangioma or the congenital lipofibromatosis, we need to find out whether it is only the foot issue, whether the foot and ankle issue, or it may be associated with the entire lower limb is involved, like the Trenary-Weber syndrome, or that would be the syndrome that will be affecting the entire half of the body. So we need to always examine. So we have the opportunity to examine the child from top to bottom and see it's a part of syndrome or only the macrodactyly of the foot. We need to find out that. What is the aim? To aim to find out what is the functional issue, relieve the functional issue, get about, sometimes it would be associated with pain, particularly patient with the meningioma or lipofibrosis or the neurofibrosis, but where the fitting of the shoes, where they have the pain. So you need to relieve that. And the third and the foremost is the cosmetic. Cosmetic is that it's grotesquely looking the foot. It doesn't look the good appearance. To get about the similar size, we may not achieve it, but it's try to get it as much as possible to opposite side. So what are the options? The option is that the soft tissue debulking. Very commonly, it will be combined with the osteotomy or the epiphysiodesis. Isolated, the soft tissue debulking doesn't work. It will require to have amputation of the toes or the ray amputation. Soft tissue debulking is commonly done with the procedure, but we need to do about a repeat of the soft tissue debulking associated with the epiphysiodesis or the ray amputation or ray resection. Soft tissue is necessary to repeat that, and whenever the great toe is involved, the result is often only the fair, and it will be required to have a repeated soft tissue debulking procedure. We remove the soft tissue which is enlarged. The second issue is there epiphysiodesis. We need to do about the epiphysiodesis of the either the metatarsal or a phalanx or a both. Why need to do about that? The first 2 years of the child's growth is faster than anything else. The physis of the child would be working very fast. In fact, the child attained the half of the foot of the adult size at 2 years. So that is very important. So if you want to do the epiphysiodesis, you need to do it quite early. And if it is a child reaches to the permanent, compared to the opposite side at the adult size, you need to do the complete ablation of epiphysis, because that is very necessary timing. Most of the time we may be too late for doing about epiphysiodesis, but it can be combined with the debulking. The third would be the commonly done is the ray amputation. If it is a massive enlargement of the single ray, then it is very important to do about ray amputation. That would be single surgery, and it is quite effective. Second time, it is very commonly used for the recurrence, because it's invariably the pathology are not dealing, so it will lead to the recurrence of that. So I'll go to the few example. That's if you see about the left side, the second toe is the bigger. If you see about the width is quite more. This is the 8-year-old child's been treated. If this is the X-ray, the space between the first rib space is even wider compared to the opposite side, and because of that, the first ray is going in the adduction. There's a metatarsal adductors on that. So the child has been treated with the osteotomy. It's called as the ray reduction, the osteotomy. It's the metatarsal shortening osteotomy along with the phalanx shortening osteotomy, and it is united quite well. And if you see that, it looks reasonably okay, but is not looking normal. So the child will require in subsequent follow-up the debulking. But what is not a good idea to take out the amputation of the great toes, because the great toe is it's very important. So the ray amputation is not a good option to do for the great toe. But second toe, if it is isolated second toe, we can do about the ray amputation. Second example, it will be the enlargement of the great toe. Along with that, so much that is the incrowing of the toenails are there, and it's a soft tissue so much. So we need to do about this are the X-rays where there is a dorsiflexion deformity of the IP joints. So what is needed about that? In case of that, the ray reduction, the osteotomy of the phalanx, that we reduce the width and fix it with the wire and do about a soft tissue debulking. And if you can see about that, it's not only the proximal phalanx, is the distal phalanx also done about the vertical osteotomy and reduce about width of that size. So its length is also reduced and width is also reduced. It's a 6 months follow-up and there's a 2 years follow-up, and child has got reasonably well, and ingrowing toenail has been corrected. We can see in X-ray soft tissue. I don't have the photograph, but in a soft tissue we can see it's symptomatically is quite free, and the child is doing quite okay in the follow-up. The third case where we can see there is a grotesque deformity of the second and third toes, where there is a reasonably looking, the first great toe is okay, but the second and third is really the wide, where it's looking, it's grotesquely wrong. So what is done that we have taken out about the ray, and along with the phalanx we have taken and the metatarsal also. So it looks like the ray amputation, but we kept the width in compared to the opposite side. So this is the pair of pictures. If you see in a follow-up, the size of the left and right foot, we taken the footprint, it looks almost identical. Though there are the rays is absent, but the cosmetically looking, the tripod has been maintained. The first ray, fifth ray, and the calcium has been maintained. And this is the clinical photograph of the child. It looks reasonably okay, and functionally also it looking okay, rather than having grotesque foot. The fourth case, that is an infant presented with very grotesque. We can see about the width is more, the size is more, the depth is more, all the 3 dimension it is more. And these are the challenging case where we cannot do about the ray reduction, we can't do about ray amputation, we cannot do about the soft tissue, because it's going to come repeatedly again and again. And the child has got you can see about the thigh, there is a hypertrophy of the thigh and the leg also. So we need to deal with that. I'm not going in detail about the epiphysiodesis time of the femur and tibia, but for the foot, it's a grotesque looking the foot, where we need to do about the multiple surgery. And the child was first treated with the ray amputation at the one side. And if you can see in the follow-up, child was looking reasonably okay, but where this is it's a 4 rays, you can see it's a 5th ray, it's 1 ray has been absent, but this is also we have to do in a ray reduction osteotomy. And later we did also the second times also, we removed the second toe, and it was looking quite okay compared to the opposite side. But still the story would not be over, because child is reached to the 8 years, from the infancy to 8 years. Last case, not but least, is that if you see about that, the patient has got the polydactyly, and along with the polydactyly there is a metatarsal, the head would be long. If you see that the child has got a duplication, and is a shoe fitting was a problematic, so it's required to do about the excision of the extra rays, along with that about metatarsal osteotomy aligned put with the metatarsal. You have not to fuse about the metatarsal phalangeal joint, but you can stabilize to prevent about the valgus or varus. So in short, the microdactyly is that's one of the frustrating problem. Always examine the entire body, hip, knee, ankle, and spine to rule out about associated syndromic association. Soft tissue alone may not work in the case. The epiphysiodesis, osteotomy, ray reduction, or ray amputation are the good option, can be combined with the epiphysiodesis, can be combined with the soft tissue debulking, but repeated procedure is required in case of the macrodactyly. Thank you.
Now it's time for discussion. Any question from the house? And please point out from whom this question is oriented.
Hitesh, in case of macrodactyly, there is no, neurocutaneous markers or any available. Is there any role for, MRI screening to look for any, inside whether there is any, AV malformation or any, neurofibromatosis which is leading to, this problem? I'm talking not just of macrodactyly, even it can be, hemihypertrophy or things like that.
Yeah, actually the answer is no, but for my pleasant surprise, I can give you my example. We had one child with the CPT, pseudoarthrosis, congenital pseudoarthrosis tibia, and it's been operated in 2014. It's quite reasonable. It's united very well. He's in the follow-up. Now his child is 8.5 years. The rush rod has become short. He was lost after the COVID. He came back, and the opposite side is having neurofibroma. Okay, the opposite side, not about the bone involved, but soft tissue neurofibroma, and that would become painful. So what was suggested, because MRI was not working, I asked that get the MRI of that particular part, because it was painful, because we have to revise, we can excise that part. So the father is the teacher, and he's one of the relative is doctor, which he suggested not only the MRI of the leg or the tibia, he said entire spine MRI and MRI of the brain. For my pleasant surprise, the child has got gliosis, the brain intracranial, as well as the dumbbell-shaped tumor in the spine, and that is totally asymptomatic. So those cases, even though it has been detected, we are not going to treat for the. So this is an example I said. Because he came with the 4 MRI and said, sir, these are the MRIs, just have that. So I said, I'm not going to treat the MRI because it's good. It's for the academic purpose, it looks good, but you are not going to intervene unless it is going to change the natural history.
Any other question? Any other question?
No age as such. I was just discussing with Dhiren sir, there was a child I operated, at the age of almost 2, but he had an equinus contracture of almost 30 degrees. On initial examination, such a severe contracture, I thought that definitely there must be some underlying neurological abnormality or anything. We got a neuro evaluation, a thorough evaluation done. Nothing turned up. So he was actually a case of isolated gastrosoleus contraction, which is an idiopathic toe walking. So in that case, we operated at the age of 2 because he was so rigid and he was so rigid that he was having extreme difficulty in walking, having frequent falls. So in that case, we operated at 2. But other case, in milder cases where the contracture is not very severe, maybe about 10-20 degrees of contracture is there, 10 degrees of contracture is there. Child is able to walk. Okay, I may give a very sufficient long trial of conservative treatment, physiotherapy, maybe AFOs also in some cases. There is no hard and fast answer to that. I think literature doesn't talk about, in fact,
Just add to that, actually, we don't know the natural history of this disease. So there is no point of hurrying too much early to suggest surgery. So I just say that this is one option when you are like willing to undergo that procedure. Come. Because in our cases, we used to delay as much as possible. That's absolutely perfect. And they usually don't go for additional problem like a recovery at the knee, which we see cerebral palsy. Somehow they don't go for such complications. How many cases are seen that a skin problem? Skin necrosis.
Yeah, that is we can take out also the skin with the soft tissue and say that till it is a tension-free closure we can do. We cannot take out everything, but whenever we take about the skin, we go in so much depth, so we'll not disturb the flap on either side. So that would be the key to reduce about the skin necrosis. Otherwise, if you would be very excessively taking about the skin and a soft tissue debulking, there would be, if you do about dissection on either side, it will lead to the invariably skin necrosis.
I would like to draw the opinion of the house of some of the cases, very common cases in our OPD clinics, the child coming and complaining of pain foot and the X-ray shows accessory navicular bone.
Painful, what say in that?
With accessory navicular bone.
Accessory navicular, you want to answer?
What is your take on
So
it?
in case of the accessory navicular, I generally, I'm not very aggressively operating for that. I'll give about the conservative treatment, conservative trial. I'll do about the physiotherapy, shoe insert or the insole, and then about the tibialis posterior strengthening. And even though still it's painful, I'll put a short BK cast before doing about any embarking any surgery. Quite a lot of the conservative trial.
Okay, thank you very much. Thank you all the learned speakers and the audience. Can I invite Dr. Ritesh Runu? Dr. Ritesh Runu? Dr. Ritesh Runu, case-based discussion. Please.
Good morning, sir, chairperson, sir, my seniors. I'm going to discuss about 2 cases pertaining to ankle deformity. It's not coming on the screen. Yeah. Yeah, this is the first case. You can see the video. 17-year male presented to us in OPD with deformity of his right ankle and pain on excessive walking. You can notice the deformity. Anybody from our residents? Is it visible or not? Heel valgus and shortening. This is the clinical photograph. Heel is in valgus and medial side of the distal part of leg is more prominent. And there is, on examination, there was 2 centimeters of shortening also. This is his X-ray.
Sir, can you go back?
Yeah, so because if you look at the clinically, the valgus does not appear to be at the foot, it appears to be above the ankle.
Yeah, lower part of the distal leg, just above the ankle. And
One point which Dr. John asked me in my lecture, that there is a deformity at the proximal to ankle, but there is a reverse deformity
yes, sir.
below
Subtalar
that.
compensation.
So
also.
now, before doing a surgery, we just have to ensure that that much part is the correct. Otherwise, what will happen? The child will have a varus deformity in distal, because now foot is not going to compensate. So it's very important that we examine the foot.
Yes, sir. That is the point. We noticed also that even there was a deformity just above the ankle, the patient was keeping his full sole on the, because he was compensating at the subtalar joint by creating a varus. And here we can see in the photograph also. This is his X-ray. Distal part of tibia is deformed. Anybody from the residents, can you point out something in fibula? Maybe healed fracture. This is his scanogram.
It's a result of some growth disturbance, maybe. Some sort of either post-traumatic or
growth, yes.
post-infective.
Yes, sir. Might be.
What is the
growth
past
disturbance.
history?
We'll go to that. So one possibility was trauma, second was infection, growth disturbance like fascial defect or fascial arrest, maybe dysplastic causes or iatrogenic. Some intervention may have been done in the childhood. So this is his previous X-ray his father collected and came in next OPD, that the child was having fibular osteomyelitis in the childhood. At that time, he was operated and gradually you can see that his ankle was absolutely normal at that time. Follow-up X-rays. But here we can notice that the distal part, distal tibial physis, there is a wedging, angular deformity, and now the deformity has just started. No, it is still subclinical. Gradually, the patient started developing deformity in 15 and reported to us. And this was his clinical photographs immediately before surgery. You can see that there was shortening and there is a anteromedial bowing of the tibia with the valgus deformity and subtalar compensation. And distal part of tibial physis is almost 90 degrees to the long axis of the tibia. So in this case, we were a bit confused what to do. This is the problem statement. What are the problems the patient is having? There is compensatory varus at subtalar joint also. So one option was not to intervene. Don't do anything. Anybody will go with this? We should intervene. Since there was a fibular defect, so one option was to fix the fibula and correct the deformity. And the deformity correction, the distal part of the tibia by osteotomy and fixation with K-wire. But there was an issue of shortening also. Second option was putting a Lazaro. and third is LRS fixation and lengthening. So we did simple surgery, and since there was a deformity was very severe and there was subtalar compensation also. So instead of correcting it completely, we went for partial correction of the deformity. As sir was showing the osteotomy of the distal part of the tibia, we did the same thing. First wire went perpendicular to the long axis of the tibia, and second was not parallel to the joint, it was less than that, fixed with K wires. 5-month follow-up. The patient was standing, but here now we will notice that the forefoot deformity has become prominent. He is compensating to put his foot on the ground. On 9 months follow-up, the shortening is apparent now. The heel is up. 16-month follow-up, good union, alignment is better, not anatomical. And this is 5-year follow-up. The patient is attending his college classes. Now he is comfortable with walking with shortening. 2 centimeters of shortening is there. Valgus deformity has improved. And the parents are now planning to go for lengthening, because there is around 2 centimeters of shortening. They want that at least it should be corrected now after 5 years.
Can you go back to the previous X-ray? So the talus looks very grossly tilted. Okay, so are you worried about that? Because
distal part of tibia, if you see, it is not exactly perpendicular to the long axis of tibia. It is in extension. Sorry, it is in flexion.
No, it's severe
valgus
valgus.
and flexion.
It's
both.
almost rotated 30-40 degrees that way. So I think this is something that may cause problems later.
Yeah. So in long-term follow-up, we have to see what's happening in the subtalar joint also, and also the tibial talar joint.
I think there is some compensatory reverse deformity in the subtalar joint. That's why, clinically, he's still looking straight. Yeah, that's going to be that. He'll develop ankle arthritis.
Sir.
So specifically mentioned that you have not corrected the deformity fully. Why it was like done purposefully?
Yes, sir. Purposefully, because we were not operating the subtalar joint. Because
Okay,
there was
so
a
you are worried that it
compensation.
may not compensate fully.
Yeah, we were not correcting the compensatory subtalar as well as the forefoot deformity. Therefore, we went just partial correction.
How do you rate the other modes of fixation like Ilizarov or Jess or gradual
Ilizarov is
correction
a
and gradual
better,
lengthening?
compared to all other fixation at 17 years of age, Ilizarov is a better option, because we can do a 3-dimensional correction, plus we can do the lengthening also.
And
But
gradual
because of
correction
subtalar joint and other foot joints nearby, we didn't went for that, because in those cases we cannot correct one joint at a time.
And
We
gradual
have to
correction
correct all the other.
will also take care of the compensation taking place at the subtalar joint gradually.
Yeah, in that condition, we'll have to extend that Ilizarov frame down also up to the calcaneum.
Yeah, so such a severe deformity, I think, gradual correction would give more. Now, additionally, this is a 3-dimensional deformity. Okay, you want to lengthen as well. So, in such a complex deformity, even with the Ilizarov, arranging those hinges can be very difficult. So, the modern way of doing this is, doing with the hexapod. And now we have an Indian-made hexapod, that is the DefFix system, developed by Dr. Mangal Parihar from Mumbai. Very convenient to use system, very simple. Software is also very, user-friendly. So, that is something which can be applied in this particular situation. And additionally, obviously, you would, if you correct the ankle deformity completely, you would need to correct the subtalar joint as well. Yeah.
Very good. Dr. Ritesh, please proceed for your next case.
This next case is about a 11-year male who had a surgery elsewhere for a talar fracture. And that surgery, after that surgery, he had an infection. You can see that the X-ray fixation was done. There was non-union and avian changes. The patient presented to us in March 17 after removal of screws. He had a persistent discharging sinus on the medial aspect, and he was having a stiff ankle and not responding to antibiotics by this where he was operated earlier. So this was his finding in the OPD. Pus was coming out through the scar and there was no movement at the ankle joint. Lab reports, ESR was raised, CRP was raised, and his pus culture report was MRSA. This is his X-ray in March 17. You can see that the talus is sclerosed at the fracture site, non-union. Lower part of talus, subtalar joint appears in anatomical position with some changes. And on AP view, we can see some lytic areas in the talus. Dr. Sandeep, anything you want to point out?
Neuropathic? Any?
No.
What is the history? Trauma.
He has a trauma. You can see that.
It was a compound screw was.
Yeah. He was treated elsewhere. He presented to us with a pus coming out through the scar tissue.
And the pus is still persistent.
Yeah. The moment he presented to us, screws were removed and pus was coming out through the scar tissue. And the patient was having a stiff ankle.
So the priority now first is clearing the infection.
Yes.
So I think I would get an MRI done over here, see the exact extent of where the infection is, where are the sick places, and then plan for even the calcaneum is involved. I think, the lytic lesions in the calcaneum as well.
Yeah.
And the talus body is also avascular.
Yes, sir. That body is proximal part has become avascular. So one option is to go for MRI. Anything else we can do for investigation in this case? We did only pus culture, X-ray, and we didn't went for MRI in this case as the just to find out.
So again, pus culture honestly does not tell you anything in these chronic discharging sinuses. Okay, we do it sometimes, yes, but eventually it's culture which you get from inside during your surgery. That's really going to be so ideally you should stop them on antibiotics at least 2 weeks before surgery, before you go on to surgery.
Yeah, the moment the patient was operated where he was given a lot of antibiotics. But the moment patient came to our OPD, we stopped antibiotics. No antibiotics, then pus culture was done and we didn't went for MRI as patient was not willing for that. So in X-ray, there was a deformed flat top talus, gap with a sclerosis, and subtalar joint was intact. Distal tibia was appearing intact. So investigations and treatment options were there. So one treatment option was first to take care of infection, and for that debridement is the option. And after debridement, once the effect is there, what should be we put inside? Either cement with antibiotics or bone substitutes. And then how to fix that fracture area?
So I think you need to, ideally assess that fragment, because if that is avascular, then the chances of any infection healing with that avascular fragment becomes poor. Okay, so that's one thing that you have to make a decision on.
So one thing was to find out the vascularity of talus. That is very important.
See what you did.
Is it essential to get it before debridement?
Ideally, yes. But if you say it refused an MRI, then it's different.
Because in that case, our treatment plan may change. Only with that.
The treatment plan would be just drilling the avascular area. That is probably we will add on to the surgical procedure.
It may not, because you probably, then you have to release the tunicate when you do that. Take out the whole fragment.
But the moment we'll take out that talus in the child, 11-year-old child.
11 years, the foot growth is more or less done, 12. But the foot doesn't grow beyond 12 or 13 anyway.
Because in that case, arthrodesis is one of the options. If
then if it is a painless ankylosing, then just leave it on.
Yes. So infection control is the priority, and for that we were just thinking about what incision we should use, because initial surgery was done through the medial incision. So one option was anteromedial incision or anterolateral incision. So anterolateral incision we opted for because it gives a good view of talus, and we can see whole of the talus as well as talonavicular joint also, and we are away from that infected scar. So we went for that, debrided, curated, and then we put antibiotic mixed cement. This was removed at 6 to 8 weeks. And after that, bone grafting was done. Because at the time we saw that talar surface was fine, articular surface was posteriorly it was intact, anteriorly it was rough. So we simply put a bone graft in that area. This is 5 months follow-up. The scar was well healed, no pus discharge. Ankle was still stiff. 9 months follow-up. The patient was able to squat with limitation of dorsiflexion, but it was painless. And you can see that on X-ray, talus has healed with a sclerosis, avian changes, and there is a talotibial joint surface has started appearing now. This is his 9-month follow-up. He is able to walk with a limp. Able to walk with a limp. It's 20 months follow-up. It is getting better now. Around 5 to 10 degree of dorsiflexion is possible. Here you can see 4 years follow-up. The child is now foot is appearing fine, and he is able to squat with changes in the talus, but it is painless. And this is 6 years follow-up. He is able to walk without any limp with a wasting of right calf. You can notice in his photograph that the right calf is wasted, but he is able to do all his activities now.
So I think the result looks great, but what did the graft actually do? You haven't got the fracture to heal.
Now we have just inserted the graft in that gap in the talus because it was not sequestrated, it was intact, and it has healed with a sclerosis.
Show me the last X-ray. Okay, so that's the talus is healed in that deformed position. So what is better, excising it and leaving it as a pseudarthrosis, or getting a situation where you know he's going to get arthritis later?
If we create a gap in a developing child,
12, by the time is 12, I don't think it makes so much difference here. I mean, it's a debate. Because he's going to end up with arthritis in that ankle fairly soon.
that we have to see because it is a very short follow-up, only 6 years. So after 10, 15 years, we will come to know that at present he is
osteophytes, etc., forming on the beaking of the talus, which is suggestive of him developing OA.
So after treating the infection, first priority is infection treatment. So care of infection precedes other interventions, and long-term follow-up is essential in these cases for functional outcome.
Very good and nicely presented both cases. Thank you, Dr. Ritesh. Now we end this session. This session is.
Sir wants to add.
There is one thing left, concluding remark. Can I invite Dr. John for concluding remark for the session?
We'll felicitate our chairpersons now.
Okay, good.
Dr. V.K. Sinha, sir. Sir, John, sir. Please do the honors. Dr. V.K. Sinha, sir. Dr. Rajacharan, sir. Dr. Praveen Sahu, sir. And Dr. Chandan Soni, sir. So there are some announcements from John, sir, and then I'll proceed to vote of thanks.
Okay, so just a couple of announcements. One is about the next POSICon, which is in Guwahati from February 16th to 19th. I think we should have a big delegation from Bihar going there. It's going to be an excellent program. We've got a lot of international faculty coming there, and Dr. Sukalyan is going to be the organizing secretary, so he's here. And I think this is a meeting which for all of you who are interested in pediatric orthopedics is going to be a must attend kind of meeting. That is one. There's also a POSI webinar tonight at 8:30, which is to do with complications in pediatric orthopedics. So I think this hasn't been circulated to everybody, no? Okay, so we'll share that in the group. So those of you who are interested in attending the webinar tonight are most welcome to do that. Just thank you all. I was surprised at the kind of response that we've had to this meeting. I really have to thank all the faculty, Dhiren, Hitesh, Sandeep, Sukalyan, and all the local faculty also, who I think did an excellent job, and to keep everyone interested. And it's surprising that we still have so many people here on the second day, and that is very encouraging. And it just shows that the interest to learn is something which you can't sort of suppress. Okay. So thank you very much. And I'll leave it to Dr. Jaswinder to give his final vote of thanks.
So before coming to the end of this CME program, I would like to thank everyone, whoever is present here, all the delegates, the faculties. This was a 2-day program and we had a lot of brainstorming sessions. Thank you, everyone. We had it in association with POSI, OREF India, and of course our own Paras. So thanks the marketing team, Vinod, in and out. Since last 4 months, we have been working. We had 7 sessions and the last workshop is still pending. And I think there were a lot of brainstorming sessions. Thanks special to the delegates who, as sir just said, you are the crux of this conference, and without you, our conference would not have been a success, the CME. I'm sure you would have learned a lot and everyone here would have become much wiser by the end of the day. I thank our sponsors, Depusynthesis, Cure India, Pitker, and SCT. There are a lot of workshop materials and things given by them. And it's time to felicitate our faculty now, especially the national and the local faculties. So may I invite again John sir to do the honors, please, sir. So Dr. Dhiren sir, please. A big round of applause for him. He is like so many videos, and he makes all of them himself. How he makes also, he has shown in one of the COVID sessions during that time how he makes a video. So it is wonderful the way he presents and expresses his thoughts into the videos, and thank you so much.
Sukalyan wants to learn about that. So he's probably like fix up a date and then we can spread the information in the group. So whoever wants to join in the Zoom meeting. Perfect. Yeah, that would be good. Sure.
We'll have yeah. Next, our national speaker, our faculty, Dr. Hitesh, sir. Thank you so much, sir. This is the 3rd time we are inviting him subsequent. And he's like our pillar. This POSICon only we decided how to do, what to do, and he decided for all the faculties. And I'm sure for all the upcoming events, he'll be always there with us. Dr. Sandeep Vaidya sir has come from Mumbai. Thank you so much, sir. A big round of applause, please. With the marvelous, his knowledge, expressions, the way he presents. Thank you. Dr. Sukalyan, who's our organizing secretary for the POSICON 2024, which is going to held in Guwahati. Dr. Sitanshu has already left and we have felicitated him yesterday itself. Dr. Ritesh Runu, sir. Dhiren, sir. Aye na. Sir, please. Felicitation. Dr. Ritesh Runu, sir, from IGMS. Thank you so much, sir. All our local faculties have always stood with us. Next, Dr. Ritesh Pandey from AIMS, my colleague. Thank you so much. Thanks for being a pillar of the Pediatric Association from Bihar. Dr. Saurabh. Thanks, Dr. Saurabh, and he has been always there with us. And Dr. Shashikant was not well, so he could not attend the conference. We'll pass over the memento. And finally, our own Dr. John Mukhopadhaya, sir. So requesting all the faculties, please, all the faculties from local and national, please. And finally, sir, ho jayega, sir. And I'm sorry if I miss everyone. We, as a Paras team, everyone from here, we are sorry if you have missed anyone. And finally, this was our second pediatric event. The last was on pediatric trauma. It was in Lemon Tree last year, and Dr. Hitesha sir was there. Again, we will be planning for the next year. We'll be announcing soon what all are our plans. This is a time for a feedback. I request if any of the faculties, they want to give a feedback so that we can improve from here on for the next, please. If anyone wants to say anything, and followed by the delegates also, please. Any feedbacks, please? I know we this might look a little smaller room, but we wanted to go out, but we were not short of sponsors and all. So I think, but for a specialty conference, this is enough a room for the hall.
Academic is just superb and well managed, and what we all wanted was pure academics. So we don't want much facilities as in other conference. Thank you.
Thank you. And please, you can criticize us also so that we can improve next time. We'll take care of those things. Anything, please, anyone. Yeah, you can send me, you can say, don't worry. And of course, everything is available, all the recordings on OrthoTV, as already said. Any more feedbacks, anyone? We already had a faculty picture. And finally, this is the last slide. We'll proceed to workshop. And so we have two tables at the end. And we have bone models and a rubber model. Dr. Dhiren sir and we'll ourselves will divide the faculties, and whoever are interested, please will go to the. So he says that he'll send it. Sir. Thank you.
So basically, like yesterday, I asked the question that how many of you are doing Ponsity, and almost everyone are doing it. So this workshop is probably going to become very routine for you. So first of all, we are giving or some time for the discussion. So please let us know what questions you have about that. And then we will go for the hands-on part. So what difficulties you are facing? No one has any difficulty. No, then there's like, you are afraid of asking the questions.
Sir.
Dr. John, your impression is so. Please, sir.
Sir, at times, even after correction, we find the foot is a bit small rather than to be the normal one.
That's a very, very good practical question. And a lot of time parents, they go on asking the question. We need to remember that it's the foot length, which is a problem in clubfoot, not the overall length. So the lower limb length is not a problem. It's the foot length which is a problem. And for initial 2-3 years, they go on complaining this. Now, we need to remember that when it's a bilateral deformity, we are not worried about this because anyway, both the feet are going to be small. But in a unilateral feet, the two complaint which they always make is, the first is the length of the foot is less, and the second calf circumference, which is less. So we need to explain this at some point to that these are going to be there for lifetime. But usually my experience, like initially for 1 year or 2 years, 3 years, they complain about that. And later on, I have not seen any child coming back with that complaint. So
I think it's important to counsel them before you start the treatment that these two things will remain. One is calf circumference. It is always thinner than the opposite side if it's a unilateral club foot. They'll have strength, they'll have power, they'll have everything, but it will always be thinner. So I think it's important to counsel them right in the beginning. And the foot size, not always, but very often the size difference can be more than a couple of sizes in terms of the shoe wear. Okay, so you need to counsel them on these two things right in the beginning. Tell them that there's nothing that we can do about it or intend to do about it. And that is part of the disease. Okay, because that's where the problem is. It's actually the calf muscles which are partly hypertrophic, which is responsible for the deformity. So I think this is definitely a problem. In spite of that, there will be people who will complain about it, or so maybe you should get it written down as part of your initial counseling.
yeah. So what we will do is like in the first few minutes, we will go through the presentation to again repeat. Probably everything has been told by Dr. John in the yesterday's session, but still this would be a good repetition, and probably new animations may give you some idea. Then if you are keen, I can play the video of Dr. Ponsetti himself giving a plaster. That is one option. It's a 23-minute long video. So if you want to see that, we can do that. We can play that video. If you want, then Jaswinder will share that video with you by email. So you can keep that video whenever you want to apply plaster. So it's up to you. But first of all, let's see this. That may probably ask you a few more questions. My WhatsApp number is here. So if you want any of the animations, any presentation, please let me know. I will share that with you. So what is the sequence of correction? Already we know that the sequence of correction is cave. So it's a cavus, adduction, varus, equinus. This is what they are teaching us. I would just like to add one point to that, please don't go with the idea that first plaster is for cavus correction, second, third, fourth plaster are for adduction and varus, and the last is for equinus. We correct almost everything simultaneously. So that's one thing which I would like to clarify. For cavus correction, yesterday we saw that what is cavus. So I will going to repeat the same thing like what we do it in cavus correction. So this is a hind foot for a right side. The oblique plane, yellow plane is suggesting that hind foot is in varus. Now, in relation with the hind foot, the forefoot is pronated, right? So the first metatarsal is plantar flex, then the fifth. And if you look at the plane of a forefoot, which is in a blue, please don't take a picture. I'm going to share with you. So don't worry about that. Just focus on the lecture. Now, if you see the plane are not parallel, they are in a different thing. Now, the question is like, if we want to correct cavus, what should be the maneuver? How we should correct it? We need to lift the first metatarsal. That is how we correct it. So we lift it or we supine it. That is what we need to do. And when we do it like this, it gets aligned with the hind foot. Now, just one point which I would like to clarify. When we do this, sometimes parents complain that you have already increased the deformity. So this is one thing which we need to explain, that we have done it purposefully. Because they see that now even the forefoot initially was like this, but you have over-corrected, or like you have increased the deformity. So that's first thing. For that, how do we keep the fingers on the model or on the plaster? So we have two ways. But if we do it with one finger, then we have to keep it on a medial and plantar aspect. So as shown over here, we keep our index finger on a medial side and on a plantar side. And then the thumb is on a lateral aspect of head of talus. Yesterday, we already discussed how to palpate head of talus. Can you repeat how we palpate that? Perfect. So that is how, like say, lateral malleolus is always palpable. We go 1.5 centimeter distally, means anteriorly and slightly plantarwards, and that is where the lateral aspect of fibula is. So the thumb is that it's giving a counter pressure. So this is the picture how on the child, how we keep the fingers and the thumb. The point which is like nowhere in the club foot, we invert the foot. The foot is in inversion, and please don't try to twist it in a other direction. So this is a picture which one of my colleagues sent it, and I am showing over here just to emphasize that we are not everting the foot. So in Ponseti, we are not everting the foot at all. All the time we are abducting and keeping it in the same plane. So this is the message that please don't do that. And these are the pictures from one of the book, like where we are trying to show that eversion is not the maneuver which we do it. Coming to the second step, in which we are correcting both abduction and varus simultaneously. So here the thumb pressure is on the lateral aspect of head of the talus, like the previous correction. But the important thing which we would like to understand, and I say that the Ponseti's major contribution is this biomechanics which he explained. So I will try to explain that concept. So what we do it, this is a foot model. We apply the first thumb on the lateral aspect of head of the talus, and then by the other fingers, other hand, we try to apply the pressure from the medial side of the foot. Now, instead of plantar side, we are purely on a medial side because we want to correct adduction. This is the interesting thing. The talus is in red. Oval is a calcaneum which is lying underneath that. So we are looking at the foot from top. Try to look foot as a two-level model. On the top floor, there is a talus. And on the bottom floor, there is a calcaneum, there is cuboid, fifth metatarsal. On medial side, there is navicular, medial cuneiform, and the first metatarsal. Right now, how correction takes place? Look at this. We have applied the counter pressure on the lateral aspect of head of talus, and we are applying the correcting force from the medial side of the forefoot. And this is how it gets corrected. So just we are abducting the foot and rest of the thing are getting corrected. So why and how this happens? Let's see that. Before that, yeah. Let's see this again. The navicular pushes the cuboid laterally. The cuboid will push the anterior end of calcaneum and will take it laterally. And that is how the calcaneum will rotate. This is what the correction takes place. So this is, I think, the major contribution of Dr. Ponseti. It's not the plaster technique, but this concept which he explained, that if you do like this, then the correction will take place. And sorry, the video is not playing, but yeah, can you give, yeah, you have already shown it. I will show it again on the model. In the Ponseti video, Ponseti himself is showing this thing. So like you are looking at the foot. So I am holding like this. The hind foot is in varus. Now look at, we are correcting it. Can you give me your model, because for industry take pictures model. Yeah, please. Yeah, so this is the, sorry, like this. when we are applying the pressure on little aspect of head of the chambers and when we correct, can you see the calcaneum getting corrected? So we are not holding the calcaneum and we are not twisting, we are not correcting it. It gets corrected by indirectly with the forefoot correction. That's the most important message.
And even through this maneuver, you make sure that the first metatarsal head is elevated and not pronate the foot when you're doing this as well.
So this is what the picture before the forefoot correction. We can see that calcaneum is in varus or hindfoot is in varus. And this is after the forefoot goes into abduction, the heel gets converted. Now look at one thing. It's not only the varus and valgus. Even if you look at the posterior end of calcaneum has gone distally. So there is a correction of equinus also. Look at then, compare this picture on the right. You can see that the calcaneum has gone down. The posterior end of calcaneum has gone down. So equinus is also corrected. How to carry out step 2? This is a foot model where the skin is removed. This is talus. These are the calcaneum cuboid and the other tarsal. We apply the pressure on the lateral aspect of head of talus, and this is how we abduct the forefoot. Already we discussed this. This is yellow is even in chubby child, we are able to palpate. Go 1.5 centimeter distally and anteriorly, and we will be able to palpate lateral aspect of head of talus. And then we abduct the forefoot. How frequently we change the cast? 5 to 10 days. If patient is coming from distant place, we can increase the days, or if they are going to stay in the town, then we can shorten the duration. There is no difference in the result. Always ensure that child is sedated. Now, I would just like to have a quick view. Jaswinder, how do you sedate the child?
There are times where children, a little elder children, who are very cranky, then I've asked the pediatricians and I give pedicloral syrups.
Okay, good. Yeah, Hitesh, what do you do to sedate the child? Don't sedate the child. Just Sukalyan.
Feed, place the baby on the mother's lap and give him specifiers or anything that comes down the child. Usually the parents know better about it, but no medicines.
So feeding, especially if they're being bottle fed, is a very convenient way to keep them fasting for some time and feed them just as you're doing the cast. But not all children are bottle fed. One is the mother feeding the child. Some mothers will do it quite happily. Others are a little embarrassed to do it. I avoid any definite sedation unless the child is really cranky. Okay, so I have done it once or twice, but I try and avoid that if possible.
Yeah, Ritesh.
So usually the bottle feed or sucklers, they take care of these cranky children, and maybe oral pediclor, as Jaswinder suggested, in few cases.
Okay, good. Right. Okay, so what I would suggest is slightly different. It's a midazolam, the full set injection which we use. There is a spray available. So we can use that spray. Depending on the weight of a child, we can spray this in the nose, and in 10 minutes, it will produce sedation. This sedation lasts for only 15-20 minutes by the time we can complete the plaster. Single spray for like a child less than 3 kilograms. A bigger child needs two puff. Fine, if you don't have this thing, what I would suggest is a simple alternative. We have a full set injection, midazolam injection. Use that injection, which we use it for IV. The only thing is like measure the weight of a child and half of that ml. So suppose the weight of a child is 4 kilograms. Then we give 2 ml of that IV midazolam injection orally. Not injection, orally. The effect will start after 20 minutes and it will last for half an hour to 45 minutes. So that's another way of making the child relax. Before that, always feed the child, because when the tummy is full, this will work really well. Equinus correction, already we discussed that yesterday at length. The point is like the end point. The end point is like we need to correct it up to that level. So we have a 70-degree foot going into abduction, and we have a 20-degree dorsiflexion. A lot of orthopedic surgeons, they ask that why we really want to overcorrect it. I just tell them this is not overcorrection. This is a full correction, because a normal child at this age will have this much amount of mobility. So we are just reaching up to that range. We are not overcorrecting it. Fine. So if you have any question, please ask. We have probably one of the best experienced faculty for the clubfoot.
So Dhiren, about this use of MedSed, this thing, the Mizolam as oral, this thing, is there some guideline or literature on this? Because
yes, there is a literature available about that. So the dose which is required in IV is 1/3 of the oral dose, because the absorption is poor. Yes, there is a literature available.
That is you can back up.
Yeah. If in case of problem occurs. And again, the safety limit of this medicine is very high. So don't worry about anything. And it is much more safer and shorter in action than pedicloral. So the effect of this wears off. By the time they leave the hospital, the effect will start disappearing.
So do you do this for every child?
Every child.
And it doesn't make the child laugh. The plaster doesn't make the child laugh.
Yes, that's again a very good question. Yes, when we are applying the foot or when we are correcting the foot, yes, child will cry for 2 or 3 minutes. But as soon as that part is over and the temperature of the cast comes down to a normal, then again child will start sleeping. But during correction of the foot part and when we are applying the plaster, probably a temperature or a stretching sensation will wake up a child even with this. So it's not that powerful that child will remain sleepy. Yeah.
So we start this treatment nowadays at 1 week or 5 days or 7 days. You still give it to them?
Yes.
Yeah, because I at that stage usually children are not a problem to cast. So I would personally avoid it unless I have to do it. That's all.
Yeah. So if child is like, say, my criteria of starting the treatment is 2.5 kilogram, that is first criteria, and second is 15 days is over. I don't now start. In the past, I used to do it at 2 days, 3 days, but now I say that we start at around 15 days. So I have used with these 2 criteria, I have used in all patients.
We start by about 5 or 7. I mean, if they come, they don't often come at that time, but if they come within the first few days, I usually just say, let the child thrive, be happy that he's feeding properly, etc. And by the end of the first week, I would start the casting.
Say it all depends on your comfort zone. If you are not comfortable with this option, please don't try it. I have used it, so I have become more comfortable using it.
Sir, one problem which I think most of the beginners face while putting the plaster is like they are able to locate the tailor head without before
without the soft roll.
But once they put it, it's very difficult and they struggle to locate that tailor head again. So is there any tip and trick for them to means how to?
Not frankly, like would you like to add to this, because I don't have anything, but fine. Like, see, once you know that the lateral aspect of head of talus is there, and really we don't keep our thumb all the time, we just go on rotating in that area. So fine, in most of the cases you will be correct. John, would you like to add on to this?
Once you locate it, you can actually feel that sort of movement in the forefoot as opposed to the talus. So when you're doing it, if you're getting that same movement, the talus is your fulcrum, so that's not moving, the rest of the foot is moving. So if that is happening, you're probably okay. And of course the lateral malleolus, you can, so don't use thick soft roll, okay? So use thin cotton or soft roll, whichever you like, but use thin layers of it rather than.
Okay, anyone has come across a problem of sore on the medial aspect of proximal thigh? Have you come across that? What do you do for that? Okay. Okay, good. Anything else? Okay, let me give you a very good suggestion that works very well. Apply a Tegaderm. Tegaderm is a plastic film. So apply that on a medial side near the edge of the plaster, and it will not make the skin wet, and you will never get the problem of sore. So that's another practical tip I would like to add with you. Yeah, so like after, no. We keep it for 7 days. So we remove it. When we remove the plaster, we take out. We allow the skin to breathe for 15-20 minutes between the two plasters, and then we apply the new Tegaderm. But the thing is, like, through Tegaderm, the air goes. So it's not air-proof. It's waterproof, but air goes through that Tegaderm. So now I request Hitesh, Sukalyan and Sandeep to demonstrate that technique.
So before we break, I've added Dhiren sir to the delegates group. So you can ask all the questions and everything, videos, everything directly also. And we'll have a group photograph, and then we'll go for the workshop. All the delegates, everyone, please